Started, yeah, okay, that's great. We've just got some matters of housekeeping that I'll just do quickly before we go into apologies and introductions, because we've got some visitors here. I'm sure that would welcome introductions, and for those that obviously watch this meeting online, it's a very helpful thing for us to do. So in terms of housekeeping, we're not expecting a fire alarm, are we, Kirsty, unless something's remarkably happened since I left upstairs. If there is a fire alarm, then we take the exit there, and we convene in furthest corner of the car park. Thank you. Apologies.
We have apologies from Leslie DeBell, Adrian England, and Sarah Norman. Unless anyone else has got any other apologies.
No, and just to confirm that we are quorate, so I'll deal with item 3. So let's do a quick round of introductions. Bob, do you want to start?
Hi, everybody. I'm Bob Curtin, Deputy Chief Exec of Barnsley Hospital.
Smith, Vice Chair of Health Watch Barnsley.
Hi everyone, Jane Siddha-Kumar, Chief Nurse for South Yorkshire ICB for Barnsley.
White, Public Health Principal, Barnsley Council.
Alex Tinkersley.
Batnell, Head of Communications Engagement in NHS South Yorkshire.
That's what the Chief Executive Officer.
Field, Clinical Services Director in Swift for Community Services. Anna Naylor, Chief Finance Officer, South Yorkshire Integrated Care Board for Barnsley.
We'll get this right, won't we? Wendy Lauder, Place Director for Health and Adult Social Care.
Kay Morgan, Governance Assurance Manager, Barnsley Place.
Paige Proud, Risk and Governance Lead, Barnsley.
Debbie Wycombe, Deputy Place Director for Barnsley in NHS South Yorkshire.
I'm going to go to the screen and give Marie a chance to settle. Martine.
Martine's on mute.
Nearly. Hello everyone, it's Martine Tune. I'm the Chief Nurse and Chief Exec of Barnsley Hospice.
Thank you. Julia.
Hi, I'm Julia Burrows, Executive Director of Public Health and Communities. Really sorry I can't be there with you in person.
Thank you. Madhway.
Madhvi Guntamukalam, GP, Medical Director for Barnsley SYICB, place-based.
Thank you. Dave.
Yeah, Dave Ramsey. I'm Director of Services with Swift.
Thank you. Salma.
Director of Strategy and Change at Swift and Deputy Chief Exec, and here for Matt Brook.
Moving around on the screen. Jane, I don't think I've done Jane Holiday.
Hello, I'm Jane Holiday. I'm the CEO at Barnsley CVS.
Thank you. Mirban.
Hi, Mirban Ghani, GP and Chair of Barnsley Healthcare Federation.
Thank you. Angela.
Afternoon, Angela Fawcett, Head of Safeguarding, Deputy Chief Nurse, just shadowing Jane this afternoon. Thank you.
Thank you. Richard.
Afternoon, Richard Jenkins, Chief Executive of Barnsley Hospital.
And I think that's everybody that's joined us on Teams. And Marie.
Oh, sorry, Marie Burnham, Chair, Swift. Afternoon, everybody.
Okay, without any further ado, welcome, Alex, if you want to, and Emma, and we've got a story to share.
So a priority for the health and care plan for 2022-23 was to strengthen our joint approach to prevention by working with communities, the voluntary sector and partners, focusing on preventing and reversing deconditioning for older people, bereavement, emotional well-being and resilience. The video we're about to show you is an example of how Barnsley is meeting that priority. It's a short video of a Barnsley resident talking about how they managed a fall, having attended one of the Barnsley older people physical activity alliance groups. It's a simple example, really, of how prevention interventions and services really make a difference to individual lives and potentially reduce the needs for more costly services. As a result of the BOPA pilot project, we've now got 13 fall prevention classes across the borough for our residents, and another 5 coming in the next month or so. And there are around 180 other activities across the borough happening for over 50s to improve their strength and balance. This wouldn't be possible without a strong partnership approach that supports our co-design, that supports co-design and empowers providers to develop a more activity for residents. The Alliance has strengthened relationships between services and providers, upskilled the third sector, private providers and volunteers, and as you're about to see, has given our residents who attend the classes the confidence and resilience. We just play the video.
Hi, this is Linda from the Birdwell Community Health and Wellbeing Group. She just wants to tell us a little story about what happened last week to her.
Hello, I just want to say thank you to Sarah for showing me some exercises last week, yoga, because a couple of days after the lesson I was putting my tablets away and one fell on the floor and I reached down to get the tablet and I fell off the stool, went with a bang. Breathe and do my breathing exercises. And then I thought, now then, last week was the first time I got down on my knees for years. And I thought, Sarah taught you and you did it last week, so you can do it again today. And thank the Lord, I've managed to put my hands on stool and get myself up. And I went straight on my knee, straight from my knees, straight onto the stool and sat and thought, don't panic. And I sat there and did my breathing exercises. And so I want to say thank you very much for learning me that because it came in really useful. Thank you.
And was that the first time you'd been down on the floor and in the class last week in the health group? Yeah.
Yes,
Because you were very nervous, weren't you?
Yes, I couldn't believe it when I got down last week. And then when I fell, I thought, by gum, I can't believe this.
Yes.
And I didn't panic. I just told myself, keep calm like I did last week, like you showed me.
And that's wonderful. So it's just showing that the health and wellbeing groups can work. So the breathing exercises kept you calm and you knew the floor, you can get up off the floor because you did it for the first time. Was it been 7 years you'd been?
More than 7 years.
More than 7 years
than
you've been on the floor. So thank you for
Yeah.
trusting me. And
Yeah.
let's hope this little success story inspires other people to know the floor is a safe place because we don't want the first time we go there after a fall. We want it to be a place that we know we've got control of.
That's right.
So thank you very much. Well done.
Thank you.
If this lady had not been able to get up from the floor by herself, we would have had to either one of our services would have had to respond to that. So our community first responders, urgent care, or an ambulance call out. The BOPA pilot is just one part of the falls pathway and represents a real positive way of working in a partnership across Barnsley with a wide range of organisations. The Falls Pathway Review is being undertaken also in partnership, and I want to show that any recommendations that come from the review will be jointly agreed, mirroring the Barnsley Old Physical Activity Alliance approach, and ensuring strong relationships between our services. So just any reflections, I guess, from that video from anybody at all.
Any reflections from people? I mean, I'll kick it off really, and I guess as a family carer that looks after my mum, not a Barnsley resident, sadly, but anyway, my mum's 94 and she lives at home independently, and I had the joy of spending some time with her over the weekend, and during that time she had a fall. And I actually thought, if only my mum had had the benefit of actually experiencing and connecting with some of the offers that we've got through BOPA and its efforts, she would have been so much more confident and calmer. I mean, as an individual, she went into absolute total spin, having just a negative impact on her overall well-being, blood pressure, all sorts of things went into a bit of a spin, I'm afraid, during that sort of hour. And I would have had to call. Fortunately, there were some friends and families that could help in the immediate vicinity, but it would have been a call out for an ambulance because I was quite worried about it, but we managed to resolve it. But it just brought to life the significance of this sort of activity. So I welcome reflections from anybody else. Jill.
I mean, it's a really powerful video, although it's only short, isn't it, Alec, that in terms of thinking about the impact on an individual's life. And I think obviously we're involved in the various discussions. I think one of the things is how do we then use that transferability for people that are housebound and in care. I know there's work going on in care homes, but I'm thinking about the huge swathe of individuals that we support within their own homes that would benefit for some intervention of the same area, I suppose, that can't get out to the offer that's out in communities. I'm not saying everybody, but I think actually it's about how we use that transferability of that skill set and approach into a wider audience, really, that, you know, we know that people that live at home, they're frail, they're elderly, they're housebound, they've got deconditioning issues, the same as the general population, if not more so. So actually, I'm really interested in how we can transfer some of that knowledge and skill set into all the core services, really, without it being too onerous, obviously, on clinical staff.
Yeah. It's equity of opportunity, isn't it, that this brings, really. Jane, did you want to come in? And then Mervan.
Yeah, if I can just put in, up till toward the end of last year, I was the CEO at Age UK Barnsley, so I was there for when this kicked off. And by the time that I left, there were 55 different providers involved in across the borough. It was a really brave way of moving forward and procuring what was a very needed service for its time. And what it sort of showed to me is a couple of things. It could have been a consortium arrangement, but it would never have had the number of organisations in it that have, as a result of it being an alliance. And one of the central sort of like parts of the SLA around making it a free service were immediately ditched by all the providers who said that would actually destabilise our business. So what has been done instead is they are actually subsidised groups now, and that makes it far more sustainable. So, and yeah, I just want to say well done. It was a really brilliant way forward, and hopefully we can have more times when the VCS is brought in and sent away to sort out some of the issues that we're facing together, rather than just having something procured.
I couldn't agree more, Jane. As you probably know, our alliance-based efforts and collaboration really are landing some significant benefits, and long may it continue. Merban?
I'm just going to pick on something Jill said and just expand on that. Our PCN has been undertaking exercise classes in care homes. So our care coordinators and health and wellbeing coaches. So I think the data for that will probably take a little while to look at. Does it actually reduce the number of falls and what impact that has on A&E attendances and also call out for ambulances. But there is work happening. But then the actual use of this in people who aren't in a care home, over the age of 40, muscle mass decreases, and then it's probably associated with worse outcomes as from the data that suggests. So something for us listening in and be around the table, we should perhaps undertake more of these exercises. But the important point that Jill makes is that, okay, you might have these individuals who could go to these exercise classes, you've got the care home work, but there is a group who are stuck at home and nobody actually does anything for them that I'm aware of in this field, unless their families take them out. And then they also are probably high users of health service and social care as well. So there's a lot that can be done in prevention. And this is a really good example of it. Thank you.
Do you want to come back on some of the observations?
Just on that last point, I'll touch on that within the presentation, what Jill said. So I'll
On the item later on. All right. So we've got an item later on the agenda around the falls pathway review. Should we pick up those points a bit later on? So thank you though for bringing that story in here. It's really important messages we got from that. Okay. Let's move on to item 5, case involvement report.
Yeah, so a short report this month, but quite a lot in there. So this is the involvement report that we bring back at each meeting to give some assurance of the work that's taking place, but also to give a bit of a flavour of some of the conversations we're having with people that use services and local residents. So I won't go through the whole report, but I just wanted to highlight a couple of things. So we've got a much lengthier paper on the agenda later on about the integrated care partnership strategy, and that's That's got the full engagement and feedback report in there. So really encourage colleagues to read some of the items of feedback and some of the insight in there. But just noting that that engagement period has now come to an end. So we're busy taking all those insights, looking at how we can use them both to inform the draft strategy, which is what's happened in, and you'll see that in the paper later, but also how we then take that into sort of just business as usual, how we make sure we make the most of what people have told us. And then I think I've said at these meetings before, haven't I? But it's the so what bit now. So how are we using that information, and how are we making sure that it influences either the decisions we're making or the types of services that we're designing. So that piece of work, big bit of work, is that phase of it is coming to an end. I suspect there'll be much more as we continue that conversation. And then secondly, I just wanted to probably more formally note for this meeting, because we won't have had one of these before. So we've got 2 GP practices who signalled that they are interested in closing a branch surgery. So those practices now are undertaking a period of consultation, which ends, I think it's tomorrow. So that's been going on for a while. We've talked to our colleagues at Overview and Scrutiny before this process took place. And just for colleagues to be aware, so that's part of the requirements, is to talk to Overview and Scrutiny, outline the engagement or consultation approach, and they then review that, come back to us and say, actually, we think that approach is in line with the activity that you're going to be doing, or actually, no, it's not, please go out and do something else. So in this case, they approved that, they were happy with that. So so that sort of carried on as we've described. So it was just a signal that that is happening. That's something that, if and when a proposal comes back into us, the decision is likely to be made at the committee part of this meeting, or at least a recommendation will be made. So just noting that formal consultation is coming to an end tomorrow, and we'll be picking that back up in this meeting, most likely at some point, with a full feedback report. So just noting that, as I say, we won't have had one of those probably whilst we've had the partnership committee in place. And then picking up on a conversation we had at the last partnership meeting, so just signalling now that we've kicked off the work around the all age autism strategy. So there's quite a lot of work taking place around that, really positive stuff, working with people who are autistic, their families, carers, and other colleagues working in that space, and actually co-designing the way that we're going to do that, to make sure we've got the language right, to make sure we've got the ways that we're going to be talking to people right, so actually we get a really rich response and people feel able to contribute to that, and then able to influence the strategy. So so that work is taking place. And then just to formally note, so the Barnsley Involvement and Equality Group is a formal, I'm not calling them subcommittees, are we? But it's a subgroup of this group in terms of the governance, and they met for the first time last week, which is really positive. And that oversight group has already picked up a few more things coming out of this group, but also recommendations that they want to feed back into this group at some point in the future. So we'll bring those papers back, and I sit at that, and Jane sits on that. So there's a link there, isn't there, between this partnership board, that oversight group, and then also the quality group that sits alongside us. So some positive steps there, I think. So I shall leave it there, and it's for noting and assurance, this particular paper.
Thank you, Kirsty. Did you want to mention the emergent narrative piece of work?
Yeah, so we've included that in there. We've I suppose if the word narrative isn't familiar to you, it might sound a little bit fluffy. So the way I describe it is, can we describe why we're doing what we're doing, how we're going to be doing it, and what we're doing? So if we collectively can describe that, and also we can understand what the people using our services, local residents, think about that in terms of health and care, can we marry those two bits up? And actually then, when in the future we're talking about the work that we're doing, the way we describe it, perhaps some of the ways that we visually communicate it, it all has a look and a feel that is built up from what local residents are saying, but also what we're thinking and what we think matters. But particularly that, why are we doing what we're doing? Why is it making a difference? how we're doing it. So, you know, actually we're doing it as one team, we're doing it collaboratively, and then the what bits will fall out of that. So that's a piece of work that we're kicking off. Now it'll take place over the next couple of months, and we'll bring back sort of the outputs and the proposals of that back to this board, and then hopefully as well colleagues from this board and the delivery group and some of our subgroups will be involved in shaping some of that as well. So everybody get an opportunity to feed into that process.
Okay, so questions from that. Richard?
Yeah, thank you. Just coming back on your point about 2 GP branch surgery closures, I may have missed it, but I was interested to know whether or not that consultation involved partners in terms of impact on things like people's ability to access primary care and therefore their likelihood of using A&E services instead, for example.
Yeah, so the way that it works is, so if we were instigating the change, it would be our consultation. Because the GP practices themselves have instigated that change, it's their consultation. So we've advised them, we've said, actually, these are the people that you need to be consulting with, so that when you send back your report about what you think should be happening, then we can take that into account. So that there is part of that. And then we also have the opportunity, once we receive that sort of period, the next sort of bit of the period where we form that report, and actually that will guide that. So that's probably the next stage, that will be the next opportunity to do that. And it will be related to those 2 specific practices, not necessarily all practices, but clearly those 2 practices. So yeah, yes is the short answer.
So if I could come out, should we expect to see some sort of impact assessment then in terms of what that'll do on all of our services that we can comment on?
Yeah, and I think Jamie can add to that as well.
Yeah, I think Richard and others, I guess where we're at is an approach from the practices indicating that they're wishing to formally submit the application, which we would then consider. As part of that, we would expect them to include, and it's from them, the outcome of the consultation and their impact assessments in terms of equality, access, impact on services. Once we get that, what we would need to do is an assessment of whether we would see a reduction in access to primary care, GP practice appointments, etc. as part of that. And if there would be knock-on effect, not just for other services, but or other services that are not primary care, but also other GP practices. Because what this is an application to close branch as opposed to close the practice. So we would expect that the GP practice would still be providing a full range of services for all of their registered patients. Patients may make a choice around changing if that affects location. And I guess the other bit that's quite important, and we had quite a good and a long session with all of the elected members in northeast in the days, is that whilst practices overall got a requirement to their contract to deliver services between certain times for all their patients, branches are often not full-time running a full range of services. They're there as outreach to provide a bit more of the accessibility, so may only be available certain days, may not have access to certain types of clinicians. So all of that needs to play in. But yeah, once we get the formal application with the view from the practice, we then need to form a view as the ICB and with partners as to whether that will have a detrimental impact for one patient, which is most important, but nearly as important, all of our other services, and we'll do that and share with everyone.
Okay, thanks, Mark. Did you want to come in?
Yeah, just a couple of points if I can. Thank you, Chair. I note from your report on item 3, Kirsty, you're bringing together a time-limited advisory group of people with autism, parents and carers, to co-produce your engagement approach with your new strategy. Has thought been given about that group you're bringing together to feed normally into the Barnsley Place Autism Delivery Group, so we do have patient representation and carers and family representation going forward? And the second one from colleagues within Health Watch, one of our issues is, have all the GP surgeries restarted their patient involvement or participation groups? and how going forward will that information be collated from those groups?
Very helpful question. Do you want to take the first one, and perhaps James, do you want to take the second?
Yeah, I can probably add a bit to the
Oh,
second as well. So the first one, yeah, that's sort of my hope. So on that first one around convening that group, I think it's the first time we've done it. We've talked to the steering group about the approach on this one, and they've approved it. So they've given us the nod, the go ahead to do that. And I think this will almost be a let's see if we can find some people that are keen and willing to be involved, and then expand that conversation. Because what I don't want to do is to try and do everything all at once, and put the individuals, particularly who are giving their time and their experience, in sort of a position where you know, they might be happy to do one thing but not everything. So yeah, that's my hope, that we can start to build on that probably. But yeah, any insights, or well, not insights, but any sort of advice or guidance that you want to give us on that, that will be really helpful, Mark. And then secondly, in terms of the GP practice patient reference groups, if I can give a bit of an update and you want to add the rest to it. So I want to say last month, I think it was, so the all GP practices filled out their submissions on what they were doing in terms of their practice patient reference groups, and we're just bringing together, or we will be bringing together, the sort of the view of that and how they're doing it. It's a completely mixed model. Clearly the lockdown had a huge impact on that, so we thought, actually, if we've got the audit, who's doing what, where are they doing it, where are the areas of best practice, and then we'll take that forward. So we'll certainly share that with Healthwatch, because I think it's really important as part of the work that you do with GP practices on some of that. And I know you're also doing some work with the primary care network on some of that. So the two bits tied together.
Just got one observation to feedback from Adrian England on that. He chairs his patient participation group at his local surgery and has not been approached.
Like, well, the GP practice has done the return on their behalf, but that's helpful to understand how they're having those. Thank you, Mark. Thank you.
That's helpful feedback. Thank you, Mark, for bringing that here. I'm sure that Phil.
Yeah, just following on from Richard's concerns about the practice issue, Jamie, and the branch surgeries. I mean, my plea is that we have early engagement on that, particularly around neighbourhood teams alignment and the care homes, because it's critical that we understand what the impact will be on patients, really, as well as the service.
We'll record that as a specific action. James, did you want to add anything?
Yeah, I was going to say, I'm glad you answered that question, because I'm not quite sure what the full picture is across Barnsley, but we've certainly used it as an opportunity to do a bit of a reset. A lot of the sort of that have been with patient reference groups for a long time departed when COVID came along. So it's an opportunity to have a bit of a refresh, get people that potentially haven't had an opportunity to raise their sort of voice or things before. So we're hoping that a much better flavour of patient voices in the new reference groups.
A real appetite to have a representative approach to those groups. Merban.
Just want to pick up a couple of points. One is about the closure. I think I recognise one of the branch surgeries which is applied to be closed, and what's probably been happening over the COVID times is that the service in these branches have been reduced, and as patients have got used to the service being reduced, that's where practices are probably reevaluated. Are they better having all their resources in one place where they can deliver the full gambit of service, as Jamie said, or do they just have a GP popping into a surgery a couple of times a week? So in terms of access to GP premises, the other surgeries usually close at an A&E, so I don't think they'll be turning up to A&E. They, at worst, what happens is that those who can't actually go to the main branch and tend to actually join a neighbouring practice. And one of the things that will come up, obviously, in this review is, are there any neighbouring practices where these patients could register? So the second thing, the other part of that is that it wouldn't impact on the care home alignment, because the care home alignment takes into consideration the main surgery, not the branch surgery. So unless there's a significant change in list size or there's a closure of a practice like there was with Dr. Saxena, that's when we look at the care home realignment again. And then something about PRG. The practices facilitate PRGs, or patient reference groups, meeting up, but it is the patient referent group belonging to the patients of the practice, not the practice itself. So if, for example, our PRG didn't want to meet at all during COVID times, and we've had our first face-to-face meeting a month or so ago, but as you can imagine, most of the people in the group tend to be of the over the 65 age group, were probably deemed at higher risk. So understandably, during COVID, they didn't want to meet up. But there's nothing stopping the individual group meeting, raising and discussing concerns. And it's not for the practice to to set the agenda for them. It is the patients of the practice who set their agenda. It's not practices come and meet up, discuss issues which they raise, but it's the patients group, not the practices group.
And that's helpful to observe. I think it's beholden upon us all, though, isn't it, really, to ensure and support, I guess, the voice of the public into primary care in a representative way. And I think that's what we're trying to do, Mervyn, is to get alongside those neighbourhoods and shape that, as James, you were saying, shape that together. And I think that's our determined approach, with support from Health Watch.
Yeah, so one of the issues with all PRG groups is they're never representative. They're never representative of the population that you serve, because as I explained, I don't think there is one that truly represents and makes up the different sexes, the different age groups, the different protected characteristics, and it's often people who have got time who come. Practices have tried to set up virtual ones where they've had a bit more success with it being a bit more representative, but it's actually really difficult to get a full representative. So that's usually those few half a dozen people who are able to come along and on meet up. But unfortunately, I don't think, again, it was the same with the CCG Members Council or the patient group that they had. It was not representative of the wider Barnsley public. It's always really difficult to get involvement from working age group people and the young as well. So, but if there is an issue, then I think it should be addressed with the practice. If, for example, the practice isn't engaging or there's issues that patients want to discuss, PRG has a vital role. I know when CQC comes, they will speak to the PRG lead and members of the group. So practices know that this will happen, and CQC are really interested in listening to what they have to say.
We're on a bit of a journey, Mervyn, aren't we, with it, I think, and we'll see where it takes us, I think, over the coming months. So I'm sure we'll hear some progress updates as part of that engagement forum and working together on it. So thank you, Kirsty, anyway, for the report today. We don't have any questions from the public and no attendees for those joining us online either. On to item 7, Richard, declarations of interest.
Yeah, well, I think the report sort of speaks for itself. So we've recorded the interest of everybody who's at the meeting today, I think. There's no items on the agenda for sort of decision, but if there's anything specifically on the agenda that people wanted to flag or draw our attention to, now's the opportunity to do it, really.
And I believe we do have one, Mark.
Yes, we've got a couple actually from me. Item 14 and 24, I need to declare the work I do for NHS England on patient safety. And on item 16, I need to declare the work I undertake on inspections for CQC and the fact I was a member of the CQC expert advisory group on closed cultures.
Thank you very much. Anybody else, anything else to add on that item? You? All right, thank you for that. I think we're on item 8 now of the agenda. So minutes of the Barnsley Place meeting, we've got those in the pack. Can we agree those as a accurate record, or indeed are there any matters arising? Oh,
sorry again.
No, please don't apologise.
I wasn't at the meeting. And the other thing I think I should just say as a matter of advising on PB5, Health Watch is undertaking some work for adult social care concerning their preparations.
Thank you for that, and it's very helpful support and in that space. Thank you. So I think we're on to the action log. Let's go into item 9, action log. Helpful to see a number completed there. So just reference the second column down, BPC 5. We can close that, Jane, can we? Because we've shared the economic evaluation document from Humber Coast and Vale. I think you've received that, haven't you, Jane? Jane? You're frozen. Yeah.
Yes.
Well, I can
Yeah.
confirm.
Yeah.
I can confirm there's an email from Jane saying that she's acknowledged receipt of the email. So we can close that one off on BPC 5. BPC 10.
Wendy, can I come in here?
Yes.
Just to say, this item we're going to be covering it as part of our workshop in February, so we've deferred that.
Thanks, Julia. So that's just a forward planning item. I think it's the same for BPC 10 as well, isn't it, Julia? All to be covered off at the February session. Yeah, yes, nodded. Okay, thank you. That will do. Okay, let's close that one off. PPB 6. All right, this is just about having a bit more of a formal update, wasn't it, James? I think we're going to do today, so we can close that off. BPC 6, PPB 10. Oh, right, BPP 10. So it's probably the item here for us to talk about, Marie, which is our reflections about the structure and approach to the. Or do you want me to do it?
Yeah, I'm happy to do it. And I hope colleagues are in agreement, but clearly, please tell us if you're not. I think myself and Wendy, when we were reflecting on the agenda, and then we were reflecting on the handover and all the things that go with it, it seemed a bit pointless having 2 agendas. It felt a bit clumsy. It felt a bit like, well, you do your bit, Wendy, then we'll pass over to the partnership bit, and then we can all be nice together and hold hands. And it all just felt a bit unnecessary, really. So we deliberated about the necessity to keep partnership live and real, but we also reflected on the need to acknowledge there's an NHS statutory duty on Wendy as well. So if it's all right with you, I thought, well, there's no point in having somebody like me independently chairing the second half when Wendy chairs it eloquently anyway, and there's a statutory duty on Wendy. So I think between us, we thought it better to have one agenda, make sure it flowed better. The vice, and I was very happy not to chair it, because actually statutorily I couldn't chair part of it, so it seemed pointless. Otherwise we'd still end up with 2 agendas. So it was eminently sensible to allow Wendy to, I thought, and please have a go at me if you think I'm wrong, to chair the committee. Obviously when we set the agenda, you'll see that I'm down as vice chair, and that would rotate between all the partners. It doesn't have to be a chair of a trust, it can just be one of the other partners. And I think we should probably rotate that every year or so. And that's just to basically give the partners the opportunity to be part of the agenda setting, be there if Wendy isn't. Again, Wendy would still need a deputy for the statutory bit, should that be required. But I felt very happy and comfortable that Wendy should just chair our basically place-based partnership, our place-based board, A, from a statutory perspective, and B, the reassurance that as a partner and as representing that partnership independence, I thought that was fairly straightforward. I just think it seemed illogical. We can do what most people are doing around the country, have 2 meetings, but it's just pointless. So that was my view. I think we agreed. Is there anything else? Was that all right?
No, that's really, really, really helpful, Marie. I think we're just trying to represent sort of the observations that you've all given us about the clunkiness at times, really, and can we just, think sensibly about approach to doing that. But we are cognizant, obviously, of the terms of reference and the governance that we've already signed off, and there's an implication for that. But as Marie said, we'd welcome any comments from it.
Yeah, so just on the governance. So Richard and I are picking up a piece of work that kind of, now we've brought the agenda together, how that will then fit with the ICB governance, the scheme of reservation and delegation, because clearly the ICB has its operating framework.
Yeah.
operating within. So we've agreed we'll kind of look at all the terms of reference, put a proposal forward into the ICB then to change our place, because we'd need to change the place terms of reference, place committee terms of reference as well. So we're just making sure everything's joined up, tied together, and that we can clearly separate any sort of conflicts of interest around statutory ICB business. Yeah.
Well, I think it makes a lot of sense. So yes, I like it. And I think what a great, leadership approach to a bit of an issue, really. But on a practical note, I've got to take a paper through our board next week, and the hardest bit of the paper is explaining why we've got 2 committees. Oh my lord, explaining that, it doesn't make any sense. But what were you all saying there, Roxana, is I still need to take it through in that format.
We've not actually changed the terms of reference yet. So.
And supplementary question is, might there be circumstances where we need that format to make certain decisions or not?
There may be. Yes.
It's more like, if I'm being honest with you, sorry if it's more likely to be, Bob, but if a decision's made from a statutory health perspective, you'd need your place-based director.
So it might well still need it.
It's unlikely to be from a partnership perspective, because as partners we might make transformational decisions. We're highly unlikely to make joint financial decisions at this stage. It's likely to come through so it's more likely to be the other way around to cause a problem. That's why we thought there's no point in me chairing it, because actually we need Wendy to make those decisions still statutorily.
On our behalf.
On your collective behalf. Collective behalf.
I think the agenda setting, we said, the vice chair would always be part of the agenda setting. The vice chair would also bring in the extra challenge outside of here. Whether that was me or somebody else, I'm not bothered, but I think that's what we felt, didn't we?
We did. We try to just be sensible, pragmatic, and within the law. I guess really in terms of sort of the way that, in terms of the ICB element of this very specifically. So you're right, Bob, we might have to tinker at some time for some elements really, but yeah, helpful support from Roxana and Richard. I can see he wants to come in. Richard?
Yeah, it was just to sort of reinforce that point really, that the purpose of the 2-part agendas, if you like, is because from the ICB's perspective specifically, it can only delegate its powers and its functions and its ability to spend money to a committee of the ICB. So there will be I think there might be things that we need to do, which are those statutory NHS ICB functions, where we would need to carve out a sort of a part of the agenda, because the rules around quorum and decision making and the terms of reference for the place committee are slightly different from the partnership. So we just need to sort of continue to bear that in mind really. But I do understand the sort of intention behind what we've done, which is to streamline the business and to integrate the business wherever it makes sense to do it that way really.
So we can tackle that, can't we, through our agenda setting conversations.
I think as it evolves, we'll learn. But we can't go on with 2 agendas. We can't go on with 2. Well, I can't think it's stupid. But I think there's a way, as you say, Richard, around it, if we can, from a governance perspective, that makes it sensible. And it might be the model that South Yorkshire want to adopt alongst all its committees. I don't know, but in Barnsley it seems pointless.
Yes, we've got down what makes sense.
Yeah, we do have our senior management team meeting, which effectively is our internal meeting that we could just make part of a public agenda that invites partners. There is that bit that we hold it at the same time, probably an hour before the place committee, and it just does its business in that space. So there is a way around it.
Then this becomes a partnership board. And Wendy, then you go in, okay, who's going to chair it, which I'm happy to do. But I think there is a bit about a place-based director also taking responsibility for place.
Yeah,
I personally think that.
Thank you. So, is there any objections to that proposition? Those joining online? No, shakes their heads. Okay, let's proceed on that basis. We might hit a few stumbling blocks. We note the need to amend and adjust our governance arrangements and the documents underpinning all of that. So we'll get on with that, and we'll just be agile and adaptable. That's the whole point of this world, isn't it? That we adapt and grow into this space over time. So Okay, that's an item closed off, another item closed off on the action log. That's great. We've got BPC 9 quality report, and some questions there. Do you want to cover it under the quality item? Overall, Jane, it says a non-executive blah 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 raised and clarified how the layers of sub-working groups will add value. It's about that challenge about the fit and connectivity around quality as it's led through providers, quality it's led through place, and quality as it's led through collaboratives, and quality as it's led through ICB.
Because I'm going to raise about it gaining momentum and how we're hanging some of the things on the subgroups now. So I think that's a good place to do that.
Yeah, happy for that then. Okay, let's leave it on for now. All right, let's go through that item. On to place director update. For one section, we're on 10, we're 5 minutes behind. I'm not doing bad, am I actually?
Don't worry, I'm monitoring your performance.
So just a few headlines from me. I'm not going to go through obviously the I'm going to go through the ICP, Sheena. I think you're covering that off with Kathy, aren't you, later on the agenda? Yeah. Jamie, you're covering off planning. Of course, there's a lot of stuff going off about planning across providers, ICB and others really. So, but a few highlights from me, very much around place highlights. It's really great, really pleased that we're going to see the targeted lung health check programme kicking off in Barnsley soon, offering lung health checks for people aged 55 to 74. And my understanding is that that's kicking off in the Dearn as the first location, but I'm not sure the timescales for that. So when do we anticipate? Do you know, Jamie, when's that going to kick off?
The invites should be going out now, so it's in the next few weeks that the first appointments will start, I think.
So for those people who have smoked or are smoking, those invites will come by primary care, I understand, by your GP.
Yeah, it's run from the GP systems and then automatically sent out, yeah.
Great. Just to observe, I'm sure many of you know that there is a new SEND strategy that was launched for 22 and 25. Such an important area we all recognise. Many people are in the space of supporting our young people with additional needs in many different ways. So if you haven't seen that, please do check that out. We had some helpful celebration, I think, events for those volunteers, Jane, that supported the COVID vaccination. A number of people came together, about 230, I think, Jane, wasn't it? Came together as a thank you session for the great support that volunteers provided to the people of this town in terms of vaccination. Reconditioning games, I just wanted to mention the reconditioning games, Bob and Alec. Do you know much about the reconditioning games?
I had to push it across services, yeah.
I saw. So I think it's your urgent care therapy team, isn't it, Bob? That's
Yes, sorry.
I've keep
me there, thinking I'm not sure I'm doing that.
Yeah, no, they're brilliant. It's brilliant, isn't it? Yeah.
Yeah, some really great stuff. And we think about, we'll come on to the discharge funding later on, but an element of the discharge funding we were just talking about is about really thinking about activity, reconditioning on the wards and being able to work with Age UK, I think, as well on some of that stuff. So looking forward to that kicking off. MHLDA partnerships cracking on, I think, isn't it, Mark? We're getting that moving forward. So really pleased about the progress there. I think that'll go from strength to strength. And I'm really pleased to say that Barnes is going to be the first pilot around NHS 111. And that special line, dedicated line for people with mental health needs. So Dave's team, Dave Ramsey's team, working with colleagues in Yaz and others, working on that proposition as we go forward. So looking forward to seeing how that makes a difference for people. A few other things really. Barnsley Better Lives programme, our adult social care transformation programme is going from strength to strength. We heard a bit about that in our SMT this morning. Really interesting impacts in terms of the front door, reduced transference of people into full needs assessment, and some great work, which is like cutting out the nonsense of the number of forms that people have to fill in, just stripping that right back and actually having some meaningful conversations with people and collaborating with partners around that front door, like police, housing and others. We've got we've kicked off the we've started actually, we've got some appointments in that space, a dedicated preparing for adulthood team. So I'm really pleased because one of the areas that we've struggled on in Barnsley is transitions. So we've got the initial makings of preparation for adulthood team that will really support young people into their adult lives. And a few other things really, which we should mention is strike action. And I would honestly say that we couldn't have a better health and care goal arrangement in Barnsley, because we've really come together and really tried to have some rich conversations about how we mitigate risks together as a community. And I will say that, of course, Barnsley Hospital was up there in terms of their proactive planning for their strike preparation. So, Bob, I don't really want to say anything particularly about strikes, and it's not going away anytime soon.
No, I mean, I guess only what's out in the public domain anyway. We're just saying that the therapists are striking today in Barnes and Rotherham. You know, and you've got to support their right to do that. We had an ambulance strike on Monday. The big worry for us is the 2 more days of nurse strikes combined with the ambulance strike as well. So we're going to have to see how the impact that is. But obviously, what they're trying to do is have an impact and put pressure on the government. I have to say, you know, it's been cordial relations and all this. We think a lot about the staff that are, you know, doing the work whilst the others are exercising their right. It feels really supportive in place calls and the go calls with mutual aid office and support. We keep the system working. We'll just have to see how it goes.
Really helpful. So they're my sort of few highlights, but of course, you know, equally interesting to hear from you all about any other additional highlights that you want to share on the board today. Phil. It's just about things we're proud of. It's about pride,
I
isn't
think
it?
in terms of being proud, I know, you know, everybody's under the cosh, and I know Bob will resonate with this because we do feel like we are at times. But I think as a system, certainly in terms of patient flow, both from a proactive, preventative, going into ED perspective, and also the discharge flow. And I know, you know, we are, there's a lot of returns to do, which we appreciate. Everybody in the system has to do that. But actually, when you look across the country and you look across the ICS, actually Barnsley is really well placed. And I think that's a credit to all our staff on the ground, as well as leadership. And I think it's really important to remind ourselves that actually we're getting a lot of things right. And there's always room for improvement, because that's always my mantra. But I think actually as a collective, we understand our issues and we know where we need to improve. That don't mean that it's easy, because it's not. Partnership working is very challenging. But actually, I think we all appreciate that around this table. And I think actually it's testament to the staff that we keep getting loads of requests to go and do events, talks. We have loads of visits from all different areas. And actually somebody asked me a question yesterday in a meeting around, well, how are they using that learning from what you're sharing with them? And I said, it's really difficult to make things change overnight. And actually you have to have really a commitment and understanding of actually the focus for us always in Barnsley is patient front and centre. And actually let's do the right thing for those residents, not about us as a provider in Swift or BHNFT. And I'm not sure why people don't take the learning from us.
I don't know. I think there's more. It's almost really, you know, it's almost for me. It's not just about sitting back. I think the other thing is not just sitting back on some of the things that we're very either discharge stuff. It's not just sitting back on. It's the even better if. So we've heard in the hospital team, they're really saying, "Oh, so what's the even better if? If we really stretch ourselves, what more could we do?" So that's another conversation we're going to have, isn't it, about that?
Yeah. If I could just add to that, because I'm completely support what Jill says, and we've reflected as the team is. I feel uncomfortable talking about flu when Dr. Jenkins is the call, because he's the national flu expert. But we always look at the southern hemisphere to see what's happening. We knew it would be higher and happen sooner, and it happened sooner, and it was higher. So for England, for the UK anyway, the numbers of people hospitalised with flu was twice as high as it ever had been, I think, compared to 2017. So that had a big effect right through the system at various stages of the life cycle, including elderly people, but children and young people as well, which we've all had to sort of absorb in different shapes and forms right across the system. And we've kind of managed that through the urgent care group and the bronze, silver, gold setup. From a being selfish for a minute, from a hospital perspective, the investment we've had around, you know, a protected discharge unit, the extended ED areas, the paediatric ED and CA unit, it really kind of came together, and it was tested in the hardest possible way, and it kind of really got us through. I think also with the same day emergency care, but the really good thing is we're using it as a system asset. So, you know, the ambulance service Swift, primary care, etc., were using the services now. They're sort of getting embedded and get a bit comfortable. With the children's pathways, we're under real pressure. We kind of really pushed on primary care and James to support some of that work, and we were able to repurpose the Blue Clinic to do that. And we talked numbers. It was good going, kind of going through all that. I think for our staff, it just went beyond what we all thought it was going to be, and we don't use the Q word ever, but it's been quite surprising to see how it's been slightly less busy in the last 2 weeks, but people are almost
in the hospital.
Yeah, in the hospital. Yeah, yeah. But I think we had our fair share of going through it, but people are taking a pause to thought. We've got some really exciting stuff coming up, so we're really excited about our new critical care unit opening. So we'll be telling people about that as that comes online, and we start in phase 2 in the community diagnostics centre and stuff. So there's a lot of other stuff going on as well. We've been talking in the last couple of weeks about the equality agenda, sustainability, anchor institutions, health inequalities. So yeah, there's lots going on.
Huge amount.
I think the big thing is about Barnsley for me, and I haven't been in it that long. I think it's because relationships are based on trust, and they're not based on organisations trying to acquire or merge, or there's no kind of threat from any organisations about staff on the ground working together. And that is about trust and teamwork at the leadership level. And if the leaders behave like that with each other, then your staff will at grassroots. And you can see it just reaps benefits all the time. And I think that's what they don't take back to their own places, a lot of people.
Yeah.
Well, I think that's always the common message, isn't it, Jill and colleagues here? They say the same thing. Say the same thing all the time, and pay attention to the formal and the informal. Yeah, as well, really, in terms of time spent together. I think it's helpful to hear from the James. You want to come about the Primary Community Alliance?
Yeah, I mean that's again a new initiative that we've started, that we've been working together for a while between primary and community care. There's a lot of really positive work going on. We had a board meeting yesterday. One of the big pieces of work that's come through that is around students' mental illness and how we're going out supporting them with annual health checks, which will have a positive knock-on effect to the rest of the system. And we're looking at what else we can do from obviously the priorities of the system. One of the big things that we want to take forwards is around care homes. So Andrew Osborne came and did a presentation for us. So all these things linked together, and having a strong partnership between community and primary care, I think it's vital to make sure the rest of the system works effectively. So we'd like to be able to keep people updated with that going forward as well.
It's a really good idea, actually. We'll think about that. I think, James, about how we do that. I flew with hands. I don't know who's first, but Mark and then Jane.
What I'm interested in, James, is have we got a system yet for reporting the information from the new was not brought policy? Because that fits in with the SMI, learning difficulties issues, etc. I just think we need to know how that's going. If I ask you, put it on your radar, please.
Yes. Can I just do a quick
Yeah,
update? I think it's a really important point, that, because it's part of thinking about how we make those reasonable adjustments for those individuals. And I think actually, in the work that we've been doing around the SMI work and the LD health check work, linking in with colleagues in public health and the wider system, obviously we have got an overarching was not brought policy. How we then implement that, get people on board at a clinical team leader level is really important. And I think it's about developing their understanding of what that was not brought policy means to them in their service offer and how they organise themselves. And certainly from a Swift perspective, looking at our things that we do that are outpatient type appointments, not visiting people in their own homes, is really thinking about what that policy means, and actually what are those reasonable adjustments that we need to make. And actually that links into some broader training as well, raising awareness around serious mental illness, learning disabilities, dementia is the other area where that is a particular problem. And understanding actually those cohorts of patients that aren't accessing services, not making the assumption that they're just not turning up.
Yeah.
So I think there is a piece of work, and that actually does link in. I mean, it's individual service level. We've started capturing that data and information in a different way now. And that's really useful because it's looking at how we might provide things in a slightly different way for certain cohorts of patients. But, you know, be able to keep you updated on that from a Swift and an Alliance perspective, because that links in with primary care.
Because certainly from adult safeguarding as chair of PQMA, this questions I'm going to be asked. So, yeah.
Thanks, Mark. Jane?
I was going to bring it up in my quality and safety agenda item today, but I'm sure that you are all aware. I can see Martine hasn't put her hand up to share, obviously, the good news, but the recent CQC inspection, the inspection results this week with the Barnsley has been outstanding. Absolutely remarkable result, Martine. You know, we're all so very, very proud of you and your team there. Now, Martine did step into that space before she became the chief nurse and chief executive of the hospice. She went in there and pulled it back. So just excellent news for us in Barnsley.
Well, thank you so much. How can I have forgotten that? That's appalling. Martine, do you want to come in?
Only to say thank you very much for all your lovely comments that I've had on email and Twitter and all the rest of it. But, you know, I am very serious when I say we have not done this on our own, and we have had a lot of help. We've had a lot of help, particularly from Barnsley Hospital, through IPC, through Facility Services. Angela on the call today helped me right at the very beginning, delivering some safeguarding masterclasses. So I honestly do believe that we would not have been able to do it on our own. So thank you, everyone.
We're saying more than welcome. I was saying to, I think it was to Rob Webster actually yesterday, that when any single part of our system is struggling, we have to wrap our arms around it and we get alongside them and help them to be the best version of themselves. And I think that's for all of us, really. So, but well done, Martin, to you, for you and your leadership. Huge difference. All right then, thank you for that. Probably gone a bit longer than I would ordinarily do, but it's important. All right, Jane, let's move on to you, planning.
Yeah, thank you. Some slides which I think, Paige, you're going to share, and you can flick straight onto the next page. I think it's what I'm going to try and do is just sort of give us a quick run through in terms of our approach to planning. And when I'm talking about planning, it's just important, you know, to recognise that throughout all of the year, we're planning, we're changing, we're delivering our services. What we're talking about here is what's set to us as an NHS England or NHS timeframe, always between Christmas and sort of March, June time, to confirm what we mean in terms of, or what the impact of our plans will be and how we will deliver the NHS sort of requirements around elective activity, changes around ambulance performance, mental health performance, etc. So I just wanted to sort of talk through the key elements, and I'll try and do that relatively quickly. It might seem a little simplistic. There's lots of work that will go on behind, because I think as a committee or a partnership, we'll not do it here. It'll be through all of the other groups that we've got in place. So this sets out obviously the overall time frame, and that takes us from August. But I think we've got the integrated care strategy, which probably Sheena will touch on a little bit, but I'll say which we're sort of there or thereabouts. And then between now and July, we've got to do the operational planning and develop our joint forward plan, the NHS joint forward plan, which is in effect our response to the ICP strategy. We want to do it in an inclusive way across South Yorkshire. So if you want the next slide, Paige, thank you. So recognising that there are lots of different sort of elements to this. So we've got the ICP strategy, we'll have a joint 5-year plan. There's the work that is going on across our collaboratives and alliances, looking at how our different groups of providers come together, deliver services in a different way and what impact that might have. We'll take a place-based approach. So I'll be leading, as usual, in Barnsley with partners across all different parts of the system to build up our plans. And obviously some of that will feature in our place plan, which will be subject to the development session in February. And there are also organisational responsibilities and requirements that we need to take account of and make sure that are built into our plans. So that's where we'll go to work through. It's the first time that we're doing this as an ICB. So we last year were still CCGs with an ICS, so we tried to coordinate things, but it is a slightly different approach this year. So we're one organisation and we'll have one single delivery plan. Just take us on, and I know people can't see that. People will have seen this before, and Jeannie, you're probably going to touch on, but it was just to sort of make the point that we've got somewhere to start from. So in terms of our joint forward plan, we'll be starting from the integrated care partnership strategy, the shared outcomes, bold ambitions, etc., that are set out in there, and we'll be working to develop our joint forward plan as the NHS response to that. The collective, and it's described as the NHS response, but I think we've all acknowledged across South Yorkshire that this needs to be wider than that and needs to take account of all health care, BCS stakeholders that are part of what we recognise as the system. If you just jump onto the next one. And again, I'm sorry, the slides have probably not gone out, but they will be circulated. So some of this is just so that you've got a reference. But again, recognising we're not starting fresh. So there are current plans already in place across South Yorkshire. There are common place plan priorities that we've already got set, and everybody's on with sort of reviewing that, as are we, but they are there in that middle section. And there are some South Yorkshire system-wide programmes of work which are recognised down that right-hand side, some which are the alliances and some which are more enabling pieces of work, such as those in green at the bottom around estates, digital innovation, etc., which we'll try and bring together into that plan. Well, words on this one. So I think I made the point already. The guidance on developing the joint forward plan sets out a requirement between partner NHS trusts and foundation trusts and the ICB to develop a joint forward plan. Our approach across South Yorkshire is that is an inclusive plan. It isn't just the statutory bit, which is NHS providers and the ICB. So we will make sure that it includes community, primary care, voluntary and community sector to develop, as it says in that first line, a shared delivery plan. Box has just set out, sorry, Paige. Box has just set out some of the, well, actually, you could have moved on anyway, because the same boxes are on the next slide as well. The boxes on the left now that were on the right of the previous one just set out some of the sort of requirements in there around the process, but also around who we engage and when. So just recognising there that there will be that wider engagement. Health and wellbeing boards need to be included in that work, and there's a process, as always, where we'll submit our joint forward plan, and NHS England colleagues will tell us whether it does what they were expecting and whether it meets the requirements. So that's all I wanted to touch on that slide. Again, for information, people to take away, but there's a lot of legislative requirements that link into the joint forward plan. So it includes some of the things that we often talk about: duty to involve public, duty to patient choice, promote integration, and all of those sorts of things around reducing inequalities, etc. So we need to take account of all of those things as we develop that joint forward plan. And then there are, other considerations which we've referenced around sort of workforce performance, where our current performance is good or needs to improve, and how we address that in their digital estates, etc. I'll not go through all of those. And the line at the bottom, which I can read on the sheet in front of me, just references that our joint forward plan needs to have strong links with what is our NHS operational planning submission. So the activity and performance trajectories that we set out for the next year, we'll only achieve if we deliver all of the plans that we set out in that sort of joint commitment. So that's the joint forward plan. In terms of the operational planning guidance, so this came out helpfully, as always, on the 23rd of December, to give us all some reading over the Christmas period when we've got some time away from work. That set out a number of objectives, which I think is probably worth saying. and not a surprise to us, and probably fits with what we're already part of our current plans and our current thinking. So there's nothing sort of in there that is a sort of curveball that sets us off down a different track. And the guidance set out 3 core priorities and then 3 underlying principles. So they're quite broad, but recovering core services and improving productivity, making progress against the long-term plan ambitions, and continuing to transform our NHS, which is, I think, part of what we're doing through the ICP, and developing our place partnership approaches. And then the 3 principles underneath there around smaller number of national objectives, empowering local systems, and then helpfully focusing on why we need to deliver change or deliver certain levels of performance rather than how we do that. So we've got the flexibility across the system and in place to do that. And then just breaking that down a little bit in terms of the 3 priorities. So the headline, ambitions for recovery. There's a lot more to recover than this, I think, and we'll make a progress against all of them. But ambulance response and A&E wait times, reducing elective long waits, answer backlog, improving performance against the core standards there, and making it easier for people to access primary care services. This is particularly general practice, but I think it's all primary care services. So that's around the recovery in terms of the long-term plan ambitions. Because they're the ones that have been in the news more recently, aren't they? And seem to be the politically sort of driven areas, but it's really important we keep on track with improving mental health services for people with learning disability and autism, primary and secondary prevention priorities, making sure that we address some of the challenges around workforce and make sure that's on a sustainable footing. Some of that we'll not be able to do locally, but we'll need sort of national and government support, and then elements around digital infrastructure and greater connectivity. So they're the priorities. They're what we're responding to. When it talked about having fewer national objectives, I can assure you that is fewer. It still feels like quite a lot, and there are some changes in here, but there are targets, expectations that we'll need to meet and we'll need to plan for around urgent and emergency care, which includes, we've not really measured, well, we have measured, but we've not really been able to account on the A&E performance because of the impact of COVID and things over the last few years. People know that's previously been a 95% standard. We've not been, as a country, as a South Yorkshire system, or even in place recently, anywhere close to that standard, other than for the last few weeks, when Bob reflecting it were quiet, but an expectation that this year we achieve 76%. There's then elements around community, all of the others, which I'll not go through for the interest of time, but we'll be working as a partnership team to work through all of them with the appropriate providers and agree plans for how we're going to deliver those, and that'll be what is then submitted in terms of the plan. So that's what we're delivering against. That is a repeat of the previous slide, just to remind people that there's a lot of elements that need to all fit together over time. What we will need to do, I think, over the next couple of months and even up to the formal going forward plan is make sure that we keep place partners, this board committee cited on where we get to with all of that sort of stuff, so that we're signing up to our shared plan together. And then there's just a final slide which just confirms the timescales that we are working to. So for that last section, I think, which is the most sort of pressing around our activity, performance, where we would expect the things to be and how that ties into our contracts. There's a first plan submission on the 23rd of February. So we've got about 3 weeks to work through that and submit our plan. The expectation from NHS England is that by that point, we will be relatively close and there won't be big changes to our plans. I think in Barnsley, we're probably in quite a good place because we've got the ongoing conversations. We work together with Bob and the hospital team, Dave, Jill and the Swift team around some of the mental health and community trajectories. So we'll do that collaboratively. We've got our first place planning leads meeting next week, which will help us to sort of move that forward. There's a final submission of 30th of March, which will then be tied into the signing of contracts. So there's also an expectation that contracts between ICBs and provider organisations are completed by the 31st of March. That's been challenging in previous years in some areas. And then the final date is the ICP strategy, which, whilst it should be from the start of 23-24, I think recognising where we were starting from and when the guidance came out, there's a bit of flexibility in there. So we've got to have a draft plan by the end of March, but the final published strategy that's been through governance and been signed off by the Health and Wellbeing Boards, the ICP and other places will be the 30th of June.
Thank you, Jamie. That's not an easy thing to take everybody through, and by any stretch of the imagination, it's a bit of a dry subject matter, I have to say, but it's necessary to share with you where we are and the steps along the way. Arguably, we probably should have put the ICP on the agenda first, really, followed by this particular section. But if I take any quick questions, I mean, it is what it is. It's a cycle that's to be gone through. You can see the information. Richard.
Thank you. Couple of reflections. One is, I know this is just using the terminology, but A&E isn't about A&E, it's about system and urgent emergency care. So I guess I'd be hoping that all of us together would think about how we don't just think that's about 4 hours in A&E. It's about the whole system. It's about primary care access, as we talked about earlier, for example. And secondly, I was going to make it onto the dashboard later on, but I think our dashboard probably needs a bit of work to reflect these priorities. So, for example, we're not reporting the elective activity and the must do 78-week, 65-week wait stuff in there. So I think we could perhaps helpfully just realign that to match what we're being expected to do by the national team.
Yeah, can I just check that? Yeah, that's really helpful, really. Completely agree. In fact, I had the same conversation with a number of a couple of director generals on the same subject about A&E the other day. Sad to say, and I have to be careful what I say here, actually. It was a challenging conversation because what I was trying to describe was that the success of A&E is codependent on so many other lines of the pieces of the jigsaw. For example, our ability to deliver home first model within community, step up urgent community response, efficacy of primary care. It's all of that really that really is about the way we're going to try and tackle some of this. And I shared actually, I think the Wales approach to this, the Wales plan, I think is really, really great because it brings into it all of these component parts. And Bob and I were, and a couple of others, I've talked to you, Jill, wasn't actually, then about actually we've got a UEC board and all the rest of it. We need to think a bit differently about that actually, because we need to have much more of a composite, richer conversation about those component parts. So completely agree on that. Jamie, do you want to come in?
Yeah, and I would have probably made the point, Richard, under the dashboard that it's not yet what we want it to be. The ICB have been developing their board performance report that will reflect that. We've had a dashboard that sort of arose in effect during COVID, provide us with quite a lot of intelligence, but hasn't got enough sort of focus on some of them key performance areas. And when we were doing the agenda setting, Marie, we talked about that as well, didn't we? And how we take it forward. There's just the sort of timing of how we do that. I think the other bit in the performance report, dashboard, whatever we call it in future, is how we tie that to our delivery plans as well. So it will be what are the sort of expectations and requirements and how we're doing it against them. But I've got the team working at the moment, reviewing against all of them sort of little boxes against urgent care, community. Doing about that, then what are we doing to make sure we're achieving that? We'll take that through the board, and we can tie it together then with our programme reporting against the sort of future Barnsley plan, so that we can see, are the projects, are the initiatives, are the schemes, changes, whatever we call them, that we've agreed to take forward, having the impact that we thought they would. Because I think that's important to tie them elements together as well. So in future we'll absolutely do that.
Marie.
Well, and I know we're short of time, just to, again, a bit like Richard, make an observation of it. I think from a, I know we're mental health and community, but from a mental health perspective, it's probably a little bit disappointing when you talk about the recovery bit, because mental health isn't really mentioned, long-term planning it is. When you talk about mental health, we have waiting lists, we have waiting times. They are masked largely. We deal with massive treatment time issues. It's often a hidden waiting list. And I think it's something that I would hope in Barnsley we don't lose sight of. So even though it's not mentioned actually in what they call the recovery bit, it's a profound impact on people's lives locally.
Couldn't agree more. It's often feels as if it's a bolt-on conversation, sadly, still. It feels as though mental health's a bolt-on conversation, but even worse, LDA's even gets forgotten amongst all of that. Even worse, I think, from my view. But there's a clear, I said earlier about getting alongside the MHLDA partnership, being really having a crisp, determined plan in that sort of space, getting alongside as well. And I joined the MHLDA Provider Collaborative earlier on this week. Really heartened by the progress in there. So getting the MHLDA Provider Collaborative into a space which it is now already, which is clear about the areas it wants to focus on. What's the plan around actually getting towards to deal with some of that? So we're having some conversations about programme resource to get alongside that, because we all know, had a conversation even just this week about the eating disorder pathway. Lorraine and other colleagues have raised some issues about eating disorders, so we know we need to tackle some of these sorts of things. So I think I'm quite heartened by actually the progress of that, and how the Provider Alliance, how it needs to get itself organised and start to be a sharper plan on its delivery.
But I agree with Richard. I mean, it's like A&E, it is a whole system thing. Some of the mental health people presenting more complex needs in A&E than we've ever seen before. It's that acuity problem as well. It's huge.
Yeah, we're on with the 100-day discharge challenge, aren't we, at the minute, on mental health?
Yeah.
Well, we'll see. I mean, the thing I'll also to know, I will just mention this, so I know you want to come in, and I know we're behind time, so sorry, Kathy, who's joined us. Apologies. I know hope you're not dashing off, Kathy. Oh, Lord above. Well, I'll stop that contribution that I was going to make, and I'm going to pass on then to the next item. Thanks, Jamie. Over to Sheena and Kathy then for the ICP.
Thank you. Kathy, do you want me to make a start? Because I can probably link to some of the things that have been talked about already in the meeting. So Jamie obviously has helpfully set out some of the context in terms of which the strategy was being developed. And Kirsty earlier talked about some of the engagement work that's happened. So, and Kathy's obviously pulled together the report and done a lot of the work actually in terms of the working group of corralling lots of different contributions into a relatively kind of good strategic oversight in terms of the strategy. And if you've seen a copy of it, because we shared a link to the draft strategy as part of the circulation for the meeting today. So hopefully colleagues will have had an opportunity to have a look at that. But I think, we met this week just as an ICP to kind of refresh our position in terms of where we were in relation to that. And as Jamie has sort of highlighted, this is still being tweaked and developed as we understand what that engagement picture looks like, which is really, really comprehensive. But there was an acknowledgement that there's some areas that are not yet captured. So some groups that have not yet been heard that need to be approached directly. And some areas of focus like housing, for example, where there's an acceptance that there needs to be some more work done in those areas. And I think there've been obviously quite a lot of engagement with partners as a result of sort of seeing the draft strategy, so feedback in relation to that. So there are some tweaks happening in relation to that. And even as sort of at the ICP meeting this week, we talked about, some of the key things that communities have highlighted of being important to them in relation to their well-being. So they were things like access, quality, improving mental health and well-being, support to live well, and that affordability and accessibility was really key. So you know, we do need to make sure that all of the actions and the priorities and the bold ambitions are aligned to some of those things that we've heard from our communities. And certainly they're reflective of some of the conversations that we've had today. And I think the next steps, and I think Kathy's highlighted a few recommendations there in the report, mostly which are to kind of note really. But I think the next steps are, as Jamie sort of set out, around developing that forward plan, and that's obviously where the detail is around what we're actually going to deliver. And we've accepted that the working group that developed the strategy are probably not the right people then to take forward the development of the forward plan. And so we're encouraging people to sort of put themselves forward for that in that much more kind of operational focus, I guess, really. So again, that's the, you know, one of the recommendations or actions to be noted around direction of travel around the membership. So I wasn't really going to say anything more than that. And Kathy, is there anything you wanted to add? Because obviously you've been a bit more involved in the working group.
I mean, I think the other thing that the working group are going to pick up is taking stock of the enabling plans, you know, the digital strategy, estates, etc., and just getting an understanding of where those 10 different enabling plans are all at, and then creating little mini teams to start progressing each of those enabling plans for the strategy. I think you'd probably be interested to know that we've created an easy read version of the strategy, which is really short and very accessible. So that'll be part of the communications resource that we use to share the strategy. And then there's also an executive summary has been produced as well, which is slightly longer than the easy read, but has a nice forward, very helpful forward in it from the mayor as well, and shows the mayor's support as part of the ICP too. We also are having a think about, I think also, Mariana was very clear that she wanted us to thank all of the health and wellbeing boards, you know, the collaboratives, the alliances, who had all looked at an early draft of the strategy and fed back their feedback, because that feedback has definitely enhanced and improved the strategy a lot. And it is very much a work in progress. I think the only other thing we would say is we talked about potentially having some kind of, we called it a launch, but actually it's not going to be a traditional launch. It's probably, possibly could be, you know, a week where we share the strategy, but we also ask people to, you know, have a small event in their workplace, or, you know, share it with their network, or really make sure that we socialize the strategy, and that, you know, with the workforce, with our partners as well. So we talked about it being a bit of a movement, so that, and that we tie it into, you know, people sharing their stories around how they manage their own health and well-being, or how people are supported to look after their own health and well-being. So there's something there that we will really want you to get actively involved with. Now, we're not sure whether that'll happen in the kind of middle of March, before the pre-election period, or whether we'll need more time to kind of engage with you and deliver that. So that could be after pre-election period in May, but we'll definitely want to build your involvement and your engagement with that, and those of your workforce and your stakeholders as well. And then I think the other thing that we want to really do is be very clear when we go out with the strategy about all of the representative and diverse groups who have fed into it. So, you know, we will include the names of all of the networks that have contributed and shaped it, and all of the groups and focus groups who participated in the consultation and the engagement work as well. So lots to do, but, you know, the work is progressing, isn't it, at a reasonable pace, Sheena? Happy to take any questions.
That's great. Thank you for taking us through that. And it is great that from the feedback from the public, 25% of that feedback was from Barnsley residents. I was so heartened to see that.
Yeah.
So a real thanks to Health Watch, CVS, Jane on the call, and other colleagues that really helped to support people to bring their voices forward in that sort of space. So any questions at all? No? Well, we look forward to the next steps and playing our part in it. So, Kathy, just a very particular thanks to you as well. So on behalf of the partnership, you know, you've played an invaluable role in terms of bringing a bit of spirit and energy into some of the conversations and shaping them in the creative way that you do. So huge thank you for your support.
Bless, but it was, as somebody else said earlier, this is a massive team effort at scale, you know, so we're all in this one together. Take care. Thank
Thanks,
you.
Kathy.
Thanks,
Bye.
Oh dear, she underestimates, I think, her contribution in that space. All right, okay, let's move on then. So thank you for that.
People like that, don't you?
You do. Well, I think intentionally, Barnsley put forward a team of different people, I think. I mean, we'd have preferred a more collaborative conversation about the nominations into the ICP, but others went before us. So, but we did. We brought a creative eye to that. So I think it was right. All right, okay, without any further ado, over to you guys for the Falls Pathway review. Have I missed him?
Must be an older version of it.
I've got a page missing.
No, no, sorry, I've just got a few slides on the screen.
Yeah, no, you're right.
You're welcome. You want to skip through to the next slide? So just a little bit of context to start. So we just like everywhere else, we've got an aging population, but our population, our aging population is growing the fastest in the Yorkshire number. In 2021, Public Health England produced a report on the wider impact of COVID-19 on the falls, deconditioning and physical activity. And they predicted a 3.9% increase in the number of people falling as a result of the pandemic if we didn't do anything about it. And then just there's a graph there, which is our hospital admissions for falls for over 65s. You can see there that we've been above the England average for nearly a decade now. Skip on to the next slide. So back in September, we established a multidisciplinary group to look at the falls pathway, to review the pathway. And that pathway, that review is structured around mapping services, what our services are delivering against NICE and world guidance. So a big fact-finding mission, really. So I've just put up the NICE quality statements here. I'll just pick out a few of them. So the first three tie nicely in with the pathway. So the first one is around older people being routinely asked at their appointments whether they fall or not. Next one down is ensuring that everybody that's at risk of falls has a multifactorial falls assessment. And then the third one is those that, when they've had an assessment, that they have individualised multifactorial interventions. The next few of them related to inpatients, so ensuring safety and assessments. If I skip down to number 8, we've got old people living in the community that have recurrent falls, referred for strength and balance training. And then the last one there, older people are admitted to hospital after a fall, have a home hazard assessment and safety intervention. Skip on to the next slide, please. So the World Falls Pathway guidance came out towards the end of September, and in that guidance is this pathway, and it's recommended by the British Geriatric Society. So the pathway group has met 3 times now, and we've discussed how we might look to implement a pathway similar, if not this one, on the screen. So I'll quickly just talk us through it. So at the top, and that you guys sat here might not be able to read it. Top left is talking about opportunistic case finding. So there's initial 3 screening questions that are recommended. So has the person had a fall in the last 12 months? Do they feel unsteady when standing and walking? And are they worried about falling? You then go across, so if it's yes to any of those, there's then that second box of questions. So we're still on screening here, which is about whether they've had an injury, 2 or more falls in a year, whether they're frail, whether they were lying on the floor, and whether for a long period, and any loss of consciousness. So that second set of questions is about identifying whether somebody's high risk, intermediate risk, or low risk. So if they're high risk, they should then have a multifactorial assessment. If they're intermediate risk, so they've got a gait and balance issue, but don't qualify into the high risk category, then they should have tailored exercise and also educational falls prevention. And then if they're low risk, they should just have education and general physical activity. And at the bottom, there's boxes around reassessing and following up. In our Falls Pathway meetings, we've discussed that second box around some of our services that are doing screening, whether they'd have the competencies the competencies to ask around questions around frailty and loss of consciousness. Obviously, those questions would be fine for health services, but what we need to look at is whether we'd have another service that would ask those questions for services that are referring for non-health services. Go on to the next slide. So this is looking at where we are. So where are we with reviewing what we're doing across our services? So we've this is a sort of illustrates the mapping exercise that we've done for screening. So you'll see on the left there's a list of services, starting at the top from council services down through to health services. Just picking out a couple of things. So so you'll see we've got our screening, the questions that people are asking, our services are asking, have been quite varied across our services. We've got our adult social care services asking those two initial screening questions around falls in the last year and whether people are unsteady. They then ask another set of questions around 4 or more meds, whether somebody's had a stroke or Parkinson's, and whether they're unable to get up off the floor or out of the chair or not. And then they're asked to score and then refer on. YAS have the same set of questions if they're not taking somebody to hospital, but they don't do the screening. But they are referring on via Right Care to Swift for full assessments in the community. You won't be able to see this, but under Right Care, I've written that so Right Care receiving those referrals and passing them on to Swift, but there's no triage done at that point. I've just skipped down to Swift services. So they're asking those first 2 screening questions. Then they have a second set of questions around history of fracture and whether somebody has calcium and vitamin D. So you'll see the referrals are all going within the community to Swift for falls assessments, but we have also got other services doing falls assessments. So urgent care therapy when people go into hospital, and also therapists on the wards. And then we've also got our care homes that are doing falls assessments as well. Now it's worth noting that NICE recommends that health professionals perform falls assessments. However, the World Guidance recommends that the assessment should be multi-professional. But at the moment, we've got our care homes, probably the managers and the senior staff that are doing those assessments. Just on to the next slide to touch on interventions. Obviously, there's many risk factors for falls and therefore many interventions. In the community, we've got Swift, who are offering multifactorial evidence-based interventions to meet individual need. However, research suggests that strength is the greatest risk factor for falls. And there's 2 evidence-based falls prevention exercise programs, FAME and BATEGO, that are in the table. So FAME is evidence-based for over 65s in the community, and the BOPA, as I mentioned earlier, are doing that across Barnsley. What we don't have is the ATEGO, which is the one-to-one intervention that's often in people's homes, or can be community-based, and that's evidence-based for over 80s. Skip on to the next slide. So next steps, priorities over the next few months really are to continue the falls pathway review, and come up with some clear recommendations. Produce an options paper on commissioning an evidence-based falls prevention exercise programme. Continue to support the BOPA to establish robust referral routes. Ensure the falls pathway interdependencies are flagged in other strategic work, so around dementia, osteoporosis and others. Review the falls communication strategy, ensuring we've got consistent messaging. Also review the training offer for falls prevention and continue to monitor falls and hip fracture data. Recommendations for the board, so just last slide. So to support the continuing review of falls pathway, acknowledging the role that BOP is playing in supporting our old people to be active, reducing demand on our health and social care services, and support further work to identify opportunities for falls screening, assessments, and implementation of evidence-based interventions across health and social care services. Any questions?
Thank you for taking us through that. I think it's such an important area of development, really. Any particular questions from anybody? Do we support the recommendations? And it makes sense. Richard?
I was left a bit disappointed reading this report, disappointed for our patients in the sense that it feels like we haven't got a really well coordinated service. And I think it's something that we would have hoped that we did have from our sort of partnership working. So it feels like an area that we really need to get to grips with collectively. And, it does feed into all the other things you talked about today about the way that getting it right in the community can mean that we don't end up with people coming into hospital, for example, when they don't need it. We had discussions before in the ICS, as it was, about thinking about falls from a primary prevention and secondary prevention point of view. And I wonder whether it's helpful to look at it through that lens as well. So, what do we do when someone's had a fall? Because we know that's the single biggest risk factor for future falls. And what do we do about recognising people at risk of a first fall? Because there's people who've never had a fall. There are a lot of those people at risk of it, and you need a very big intervention to get all of those patients assessed and the right arrangements around them. But it sounds like the Otago study says that is cost effective and therefore feels like we should do that. But actually, when someone's had a fall, are we sure that we don't, that we do keep them in the community where it's safe to do so, provide them the appropriate bone protection and risk assessments and support? And I just wonder whether that's something we could look at slightly separately from the primary prevention.
I think the whole pathway review is trying to we've clearly looked at who's screening and who's not screening. We're currently looking at those assessments and what's happened around the assessment. The intervention bit is going to be the really challenging bit to go through, to break down across primary, secondary, and third and tertiary what's happening around the in interventions when people fall. It's challenging to go through.
Yeah, it's not just the physical activity aspect, is it? Physical activity is only one risk factor within why somebody falls. So it's quite a complex pathway, but I think the focus that we've taken for the scope of this review has been based on that World Falls pathway with the support of the NICE guidance. But actually, I think in response to your query, Richard, it would be the bit before the World Falls pathway that we'd be really interested in from a primary prevention, public health perspective. And I think a lot of the interventions that we would offer through the pathway, which we are going to be exploring, would do both. We would keep people fit and healthy and keep that bone health and muscle strength and bone density mass and prevent them from falling, but equally would prevent them from falling in and after they've had a couple of falls as well. So it does feel like a bit of a journey at the moment, I must confess. But I certainly think there's a need out there in terms of preventing people coming through in the first place.
Okay. Did you want to come back, Richard?
If I may, I think that's helpful. It feels like it's a journey we need to get on with pretty quickly, doesn't we? And this paper is helpful in that regard. It feels also like it doesn't feel like a coordinated approach across Barnsley. Maybe that's unkind, but it feels like we could correct that because we're all around the table today. We could get a really multi-organisational, multidisciplinary, single approach to falls underway pretty quickly, because it does feel like this is something we would want to not spend a huge amount of time thinking about. And there are evidence-based approaches we need to get on with. And I think some of our excellent public health resource could probably help guide us a little bit on that.
Yeah, so I think it's about coming up with a proposition about what would great look like if we're in that great space. What are the key component parts for us to tackle together as a system? Julia, did you want to come in? And I think Jill wants to come in as well.
Yeah. I think this is something that Alec and Emma, who are our excellent public health resource, have been working on for a bit, and it'd be really interesting to get a view. So Richard started off saying that he feels a bit disappointed in how we as a system have tackled this, and it'd be really, I'd really value a honest answer from Alec and Emma about how much you've struggled to get that kind of everyone putting their shoulder behind this work. And it does feel like we've had to go for a bit of a paradigm shift as a system because it's kind of not the most glamorous thing, is it? And I remember being at an event years ago that Jane led in Shore Lane, and quite a senior clinician there said, "Oh, you don't be so stupid, you can't prevent falls," because just thinking like you can't prevent someone tripping up in the road. And it kind of showed me just how much there is to do. Actually, there's kind of around that whole primary secondary prevention bit. And I feel like we've moved massively on since then. But I know, you know, and I know Emma and Alec have been really kind of going at this for a long time, and I agree with Richard. Is there something we can do more as a system to really put our shoulder behind it?
Yeah, okay. I've got Jane and then Jill and then Mark.
Yeah, just from my perspective, having been involved in the early setup of BOPA, it did feel like it was community and voluntary services, and then there was a stop, and then there was the stuff from primary care and onward. And I think this is a challenge for us to get to work that as a seamless group of services so that people can move through it very easily and we're all talking to each other. And if we can crack it for falls prevention, then we've got a model for lots of other things. And I just wanted to sort of like mention it's not just all about falls prevention. A lot of the exercises that people are getting involved with are addressing a lot of other things like, you know, their own personal well-being, social isolation, emotional well-being, that sort of thing. But yeah, it is about making that a seamless journey for people.
Thanks, Jane. Agree, Jill.
Yeah, I think in terms of the pathway work, I think it's been on and off the agenda for a number of years, and I think it's really good that we've got a galvanisation really around that from a public health approach. I mean, certainly just thinking about the Otago programme, we do that on the intermediate care pathway. It is very resource intensive, particularly for people that are at home. And I think that, you know, we do some really good work around screening, early identification, and then where we fall down is actually that follow through in terms of having a consistent approach, which I know Alec and Emma are flagging that. I think we've got a lot of work to do across our 56 service lines in Swift in terms of having a more of a broader view on how we tackle falls, now we identify potential fallers linked in with frailty and the Rockwood score work, as well as obviously all the screening questions. So I think we've got some service areas that are doing a really good job, but it's not consistent across all services in terms of that approach and offer. And I think our main concern is the resource that this will require to actually deliver something like the Otago programme on a one-to-one for people at home that are housebound. It's very labour intensive.
Helpful reflections. I think you pointed to some of that. Mark, do you want to come in?
I'd just say, I think we've got a very, very good reopening offer within Barnsley. Very good. But when people have finished the length of time with reopening and they go to domiciliary care, it is frightening being a patient involved in that they don't know what they're doing, and the fact that it's pretty dangerous, and you could end up, if you haven't got the will and the guts, being totally bedbound through their lack of work. So I think we do need to think about how we can get domiciliary care up to scratch on this.
Yes, I think it's a point well made. I think the future design for domiciliary care, as we sort of touched upon a little bit when we came to the primary community alliance, is probably a joint design piece for the future for that particular space. Yeah. So I think what you've heard, no other comments yet. I think what you've heard is absolute support for the work. I think we're probably putting into it a bit of a sense about how do we go further, faster, really, with some of this, given the pressures that we understand and the risks that we understand, cognizant of the resource challenge, I guess, that Jill's brought in there. So I guess there's something about just reflecting upon the comments that you've heard today, having a bit of further thought. I'm happy to have a conversation with you about that, and then what might we do next in the context of further, faster, smarter, harder.
Yep. Yeah, I mean, just to offer some assurance to the board, I dropped into Alec's pathway review meeting earlier this week, and there was 27, 30 professionals on that call, you know, all committed to making a difference, all committed to working together. And I think that's why it's probably taken a little bit longer than we anticipated, because actually everybody's doing screening, everybody's identifying, you know, we're keen to do the assessments and do them right. And the multifactorial, that's what it's designed to do. There's not just the physical activity aspect of this, there's lots of other bits around vision, medication, etc. And of course, Jill's completely right. If we were following the NICE guides to the letter in terms of Otago, it is very resource intensive. So we do need to explore what we've currently got, where are the opportunities across the system that we can collaboratively work on together? And if we do need additional resource, where would we prioritise that and what would that look like?
That's very well summarised. Thank you. Thank you. But thank you for the work today. I think it's really helpful to see this in all its glory and your analysis of that. So thank you so much for joining us today. Okay, cool. I think we're on to item 14, Jane.
So the paper today, which is the quality and safety report, is for noting and for assurance. I'll take the paper as read. I'm conscious of time, so I'll just pull out some of the main points that I'd like to pull out from the paper. As the first point we shared earlier about the philosophy CQC rating, moving from inadequate to outstanding. In the report that you've got there, it is obviously been written before the CQC outcome, and that will move to routine surveillance going forward, and will be to the system quality group also as routine surveillance. Second is the arrangements for obtaining assurance and information about out-of-area placements. I'm sure you all saw the news this week with regards to Doncaster, you know, which makes this work that we are doing so very important. Jo Harrison will share some further details. She is on the call today, so she's going to take it agenda item number 16. But because we did discuss it at the last partnership board, I just wanted to be noted that we are now receiving the responses back from our out-of-area providers, and there are no exceptions to report at this time. So moving on to the update from the quality meetings, we had our second quality integrated health and care quality and safety committee on the 12th of January. And it's fair to say that it is gaining momentum. Colleagues, and certainly the feedback that I've had over the past couple of weeks, especially since the meeting, is that colleagues are beginning to see a place for things that they can obviously hook different pieces of work onto. One of those is something that Mark and the Safeguarding Adults Board with regards to tissue damage due to delays in pathways. Obviously, we can link in with the group the Quality and Safety Committee and care homes. Again, Jill and Andrew have raised, which we know we've got a place with the care home and quality improvement subgroup. So we're beginning to see things, how they are fitting. Many of the subgroups have been set up, and I'll come on to that a little bit later, and they have met. So from the meeting on the 12th, I'd just like to highlight 3 areas that we did discuss. It was a very busy agenda. We did discuss quite a few things and have quite a few actions from it. But the first area we discussed was how prepared we were collectively if a large cohort of individuals seeking asylum were to, just have my notes on, if the Home Office placed them in Barnsley. I mean, evidence, as we know, shows that large cohorts of individuals seeking asylum are coming into different areas with very little notice, and sometimes no notice. So health and care aren't being notified, and then they are, coming to hotels in coaches. So feedback again from other areas show complexities and time, the resource it takes when large numbers are placed. So we had a discussion at the Quality and Safety Committee to say, are we prepared if this was to happen? We also discussed it yesterday at the Health Protection Board. So we had another very good discussion there, Julia, yesterday at the HPB. And we have agreed to set up a very time-limited task and finish group just to make sure that if it happens, we've got everything in place that we can wrap around and support these very vulnerable people to, when they are being obviously placed in Barnsley. So the second area I just wanted to pull out from the meeting is with regards to wound care. The committee received an update on some of the issues that we are facing with regard to gaps in wound care provision across Barnsley, across all ages. This isn't just adult, this is across children, young people and adults. Patient experience being quite poor. The committee heard about the business case that's been drafted, and it was agreed that that would be shared with the Wound Care Advisory Group for additional clinical input. And one of the agreements that was made at the Quality and Safety Committee was that there would be there's an agreement to develop a Barnsley-wide wound care policy. So that is a real plus for us going forward. I have to say, with regards to wound care partners, you know, SWIFT, BHNFT, parts of primary care are providing, you know, over and above what they are commissioned to provide. But there's no clear pathway. Patients are potentially falling through gaps in provision, and they're trying to navigate these patients through a very complex system to find out who can support them with regards to their wound care. So finally, the committee discussed the progress in implementing the patient safety incident reporting framework across Barnsley, otherwise known as PSERF, and an update. That work was progressing well and is on track. We did discuss governance at place, making sure that we got that, and that was strong, and also across the ICB. So overall, all positive with regards to that meeting, which, like I say, is only the second meeting, so you know, it's beginning to feel a little bit more real than the first one, when it was just about terms of reference and governance. And the final section in the report today just gives an update on the progress setting up the Quality and Safety Committee subgroups. There's been an awful lot of work that's gone into this from the ICB quality team in Barnsley, working with partners to get them into obviously where they are and how they've been described in this paper today. So I think it's just a whistle-top stop. You know, let's take any questions.
Thank you, Jane. Any questions? I'll probably come to Richard and then to you, Mark.
Thank you. I've just got some general reflections and then some specifics about Barnsley Hospital, if I may. I mean, I think there's still, on reflections, doesn't feel that this report is a holistic report about quality in Barnsley to me. It feels like it's rather focused on the foundation trusts, and don't see anything really about primary care very much in there. And I think if we're looking holistically about the overall patient experience, the feedback from the ICP engagement exercise was that access to care and quality of care were the top things for people, and that was about not just about primary care, that's about hospital care as well. But you know, where is that, and where are we looking collectively at the quality in primary care, not just in hospital care? That's the first thing. Also, our patients, our citizens of Barnsley use other providers. You know, use Sheffield, our regional centre in Sheffield. Again, it doesn't get mentioned here, yet there's talk in the Barnsley Hospital section about non-surgical oncology, which is a service delivered by Sheffield Teaching Hospitals, not by us. We don't have non-surgical oncologists. It's a regional service. So again, I think just trying to make sure we capture it right, I think is quite important. And then Opal 4 is flagged there. It says the trust has been in Opal 4 due to 4-hour performance and delayed transfers of care. I really wouldn't have phrased it that way. We've been on Opal 4 because of the risks to service delivery. It's nothing about targets. It's about the demand on the service through winter and flu, and that should be a system approach. And I wouldn't want to blame delayed transfers of care either, because we're very well supported by partners in Barnsley. So I just wonder about getting the narrative right, about understanding why we've been on Opal 4 and other trusts have during winter. It's not because of 4-hour performance. Be really clear about that. It's about risk. And then when you look at the risks for Barnsley Hospital, you know, there's a bunch of risks that you know, I have in my head, and I'm sure my colleagues from Barnsley Hospital would have in here, which aren't reflected on here and would be different ones. One of those is the Acorn unit, which we've been talking about in Barnsley for quite a while. And I did want us to pick that up, but yeah, I have to say again, I don't want to use the word disappointed twice in a day, but I'm disappointed that this quality report doesn't flag up the concerns we've been making about the facilities that the Acorn unit is working out of for some time, which there's considerable anxiety in Barnsley Hospital's board about how that would be viewed if the CQC was to drop in and have a look at the facilities. And whilst we've been liaising with, you know, I think there's been a lot of will to support us with that, it's still not satisfactory, and we still don't have a timeline to resolution. And Bob's a bit closer to that than I am, but I think it is something, and Wendy's very, very well aware of it as well. But I just thought that's the sort of thing that should really be in this report, if this is looking at the overall quality there. So sorry, that sounds a little bit negative, and I want this to be right, but I wanted to move away from a very hospital-focused view of quality.
I wouldn't take any of the comments about negative. It's about constructive feedback, really, fundamentally. So we all want to get it right. You're right. You're right. Any other comments? Let's take all the comments first, and then we can.
My comment, Jane knows it. I think we've got to do some work with the Adult Safeguarding Board and the Children's Safeguarding Partnership, looking at what issues should come to the Quality and Safety Committee, where it can drive continuous improvement, which can't happen by the board. And I think so, medicine safety, we've heard about falls, tissue, etc. So I think there's some work that needs to be done to ensure that the right bits of the system aren't duplicating and things aren't falling through the net.
That's equally helpful. Any other thoughts from
I am, but there's a couple of
next. Yeah. Oh, sorry, Sheena.
No, it's fine. Thanks, Wendy. It's just to sort of follow on from the point that Richard's made about specifically about the ACORN unit, but equally it could be about any other issue, really, I suppose, is how we are going to capture those risks for the purpose of the place board, because it feels like it fits in the quality report there. And, you know, we're not saying that by putting things on this sort of kind of alerting people to the risks, we're not saying we've got the answers and we know what's the solution is and or it's fixed. We're saying we're concerned about it and we should all be aware of those. And I think that's what it's really about. And certainly when we've talked about it at our board, and I'll use the ACORN unit as an example, you know, we've given assurances that it's being discussed at place, but actually if you looked at the papers, you wouldn't see any evidence of that. So I think from transparency as well as the sort of process, it's important that we are all sighted on those risks. And, you know, so it's not always about, you know, we know that people are working really hard behind the scenes to address some of these challenges, but it's about that transparency and everyone being cited on the same challenges, I guess, really.
Thanks, Sheena. Sorry, who else wanted to come in? Bob, did you want to come in? Yeah.
I was just going to say, yeah, I mean, I'm support a lot of what's being said. I do think it's an evolutionary process. I think the report is moving on. We're picking it up. I got a sense of some of the, you know, the reputational stuff for place around CQC, etc. But it is going to be getting into the detail, isn't it? And you know, there is a link to that report, that ACORN, because there's concerns from, particularly from Jackie Murphy around what the situation with CQC, but there's other areas as well, and I think it does tie for me to the delivery group and how we discuss risk there to kind of support how you pick up lines of inquiry for the meeting, you know, etc. And I think it's something we need to work on together, isn't it?
So a couple of things I'd sort of respond to on that. Your point, it is evolutionary, so we need to find a balance and a value add from this conversation. That's the important thing, isn't it? Value add. So I've got clearly Kathy's got a role, isn't she, in terms of shaping this. Kathy Wingfield, the chief nurse, got a role in terms of shaping that for each of the 4 places. Start to see a bit of a consistency about how we're sort of tackling that we are achieving some rhythm in amongst us. Some helpful feedback. Thank you for that. We've also need to pay attention to our risk log and our approach to risk. So we know that the ICB's been doing some work around its board assurance framework. Part of that is, of course, risk. We've been looking at the draft risk register for that. Do you want to come in, Roxanne, to the next steps with that?
Yeah, so Richard's going to give us a bit of an update later on the agenda, but just on the back of that, I think one of the things, you know, particularly around ACORN unit type issues or issues like that we'd want to flag on our place risk register, actually then taking those through the place delivery group for a conversation about what mitigating actions we're going to put in place, where's the action plan, what actions are we going to take together, who needs to take what in terms of responsibility, so that we've got it clearly articulated to then link in actually from a quality perspective if the actions are failing for whatever reason. So it's just about how we link the 2 bits together, because things like ACORN would probably sit in a risk register.
Yeah, exactly. So it is that sort of working to that balance of attention to each of these areas. Jill, did you want to come in?
Yeah, I suppose it's just because it's really early days, I think, in terms of that larger group coming together as a different group of individuals that would normally meet. So I think it's about developing that teamwork, that approach to that, and being in a comfortable space to bring those real risks to the table and being open and honest about that. And I think the subgroup structure, we've not quite got into the right rhythm of that yet. There's two have met, two have not. And I think it's thinking about me as an individual, as on the overarching group, making sure that people are informed and comfortable in that subgroup structure to bring the right risks to the table and escalate them in the right way. And obviously, absolutely on page with Richard and Bob in terms of the ACORN unit, it is high risk, but we probably thought at that group that it's being dealt with elsewhere at the minute, so it hasn't got to quite the right place yet. So I think there is something about us working through actually what's going where and feel comfortable and have the right structure in place to support that. And I think the subgroup structure is critical because that's not quite in place yet fully, I suppose, in terms of that escalation upwards and outwards.
Thanks, Jill. And I just want to pick up the ACORN unit specifically. So in terms of discussion this morning about the ACORN unit, we know that, I guess, how can I phrase this really, that we all want to see a different model. I think that's what I'd probably say. There's no disagreement that we need to see something different. And we appreciate for your workforce, Richard, basically that's working in that environment, that they are frustrated and there's some challenges in there. But we've tried to make some short-term improvements in terms of the environment, and we obviously probably need to get a bit of an update on where those short-term improvements are at. But fundamentally, what we've agreed is that we do need a clear plan. So Jamie's producing a plan. Be a high-level plan for now in terms of our next steps, and we'll have that plan by the 31st of January. We'll obviously clearly share that with Bob in terms of your board, the hospital board. We also recognise that, and this came through some of the ministerial calls recently, which we've been trying to state really, that collectively on behalf of primary care, community health and adult social care, that as we've seen the journey of people travelling out of hospital with higher levels of needs, much more complexity of need, that need is posing challenges, there's no doubt about that, both on intermediate care, community health services, primary care and adult social care. But perhaps we don't fully understand the totality of that pressure and that challenge, but it's something that we know we need to grip and understand more effectively. To that end, and we can even just see, we've got discharge, haven't we, funding on the agenda a little bit in a short while, sorry. So we know that even this recent pressure from the government around, spend your share of the 200 million or more beds. Well, we know it's not just as simple as buying some beds. That's just going to cause more pressures for Bill's team, our team, primary care team. It's just going to compound the situation. And Merban, I'm aware you've raised some issues as well, I think, around some of the implications of the short-term solution. So our proposition in terms of tackling that is that we clearly, as I said earlier on, need to make sure the short-term environmental improvements are being tackled. That we have we bring together a rapid conversation about the current risks that we observe around the flow of people into intermediate care, bearing in mind that we've secured a whole number of additional beds scattered across a range of care homes, and it's not great, to be honest. So we need to tackle that and agree what the short-term arrangements are going to be in terms of whether or not we can concentrate that need in a few other, in a concentrated couple of care homes. So we're exploring that now. So that's a short-term piece of work around impact and risk that we're currently facing in that area. Thirdly, we believe it's time to take a good long look at the intermediate care model and what a real full integrated intermediate care model should look like, an operating model for intermediate care. So to that end, we are going to procure a third-party organisation to get on and do a rapid review, and we've started some conversations with a couple of organisations with that. Jamie's picking those conversations up. We expect there's going to be a resource implication of doing this and doing this well, and that resource implication is going to fall on both revenue and capital. And I don't know whether Councillor Houghton's still with us, and that's something we're going to have to tackle together, I think, as a system, about the capital implications of doing this properly, in my view. So that's the strategy that I'm proposing back into this group today. We'll put that down on paper. I know that's Bob, you've been asking, haven't you, for it? Can we just have this written down? So we can offer some assurance about the next steps in that sort of space. So I hope that's a helpful summary, and I'd welcome any observations. Jane, you might want to come back in terms of the quality observations in the first instance.
So yeah, completely take it on board, and thanks, Bob. It is an evolving picture. We are, we've got a quality and safety committee which is integrated across health and social care, and also with obviously providers and what was commissioners around the table. So it's a very, very different world that we're in. And thank you. I hadn't thought, well, I've been thinking it, but I hadn't thought of it in the way of joining all this up. And I think that's where the gap is that we aren't doing that, and what actually sits here and what we can take. So yeah, thank you. I'll take everything on board and put that in. Thank you.
Thanks, Jane. Thanks, Jane. Any comments at all? Any comments in regard to my summary about the ACORN unit? Nope. Okay. All right.
Good news is good news.
Tip there from Bob. Tip from Bob. All right. Thanks for the conversation. It's always very helpful. Always helpful. We've got item 15 there. It's there in terms of a summary report from our Place Partnership Delivery Group. Anything you want to highlight at all? It's there to note. If anybody's got any comments on that, can we just receive that as an update? Yeah, no comment on that. I'm going to go straight then into item 16, MHLDA Assurance Report. And I think we're joined by Joe Harrison.
We are, Chair.
Jane,
Good afternoon, Chair and members.
Thanks, Joe.
Hi. I'll take the report as read and just highlight that, first of all, it is jointly authored by myself and the Head of Mental Health, Learning Disabilities and Autism Commissioning, which I think, to note for the members, shows that close relationship between quality assurance and improvement and commissioning, the commissioning role as well. So just to note for that. I think the first part of the report concentrates mostly on our out of area patients. As we've seen, there's the recent issue around the Hesley Group and all the previous Edenfield expose on Panorama. So it's something that we have had quite a focus on anyway, but that's brought that into a really much more tighter focus now with those issues and the media coverage. So that's just, first of all, on page 1, you've just got a bit of high level data about the cohorts that we've got in the Transforming Care cohort that are out of area, and also the other people that we place out of area through acute mental health beds and psychiatric intensive care beds. There on page 2. And then there's a bit of a description really about the case management arrangements and how we follow those people through. But also we're now describing how we've got a developing quality, a bit more rigorous quality assurance process now for those people out of area. In that we've written to the independent hospitals that we've got people placed in. Now that's a changing picture sometimes. Some of them are fairly fixed into a locked rehab situation and some of the Transforming Care cohort, but some of them are very tertiary and will only be there for a couple of weeks or so. But nevertheless, the snapshot that we've got at any one time, we're trying to follow them into those areas, and we've written to the host commissioners for the people that were in those beds at the time of writing this report, and from November onwards really as well. So it's still developing that, trying to get alerted as new people come onto the cohort and just check out with those host commissioners. So we're not quite there yet, but for the cohort that we knew we had in the out of area beds, we've actually sent a letter from our health and care place director and chief nurse to the host commissioners to ask if they've got any issues or risks, and you can see the sort of the bullet points there on that page. Was it on page 2? Around the questions that we've asked, particularly around closed cultures and what are their quality assurance methods. So we're looking for that that assurance there. We've had responses from a number of the host commissioners, and I've got some to chase. We haven't received them all yet, but so far there is nothing exceptional to report. That's not to say again, that there's nothing exceptional happening, because we're not there 24 hours a day. We can't be there all the time, but this is the best we can do at the moment, and we're hoping to refine that process and get to more grips with what's happening, hopefully for the people that we do place out of area. And our focus is to repatriate them, as soon as we possibly can, and that's why we need to work closely with our commissioners to look at what provision we need in area, because some of you will remember the Mansell report around the LDA community that says they really shouldn't be placed. People with challenging behaviour shouldn't be placed out of area, but we have got provision issue, so it's unavoidable at the moment. But again, those conversations about quality improvement and commissioning need to happen between us. So moving on into page 3, we're talking about our provision in Barnsley, the acute beds that we provision from Swift in Barnsley, and then also that we have a host commissioner responsibility for a 35-bedded unit at Cygnet Oaks in Barnsley. That's on Upper Sheffield Road, and we've started some quality monitoring with them now. We've met with them, and we've also asked them for some details around who are the placing commissioners, and we've got letters drafted ready just to put the names of those commissioners on, and then send them out via secure email into the ICBs, the relevant ICBs. So that's the next phase. And we're compiling that information, but I need to chase Cygnet Oaks because they haven't given me all that information yet, and I'm needing that by the end of the month. I need that by next week to try and get that information sorted out. And then we can see that there's some work around residential placements as well that we need to do. We do have a few people, including young people, placed out of area in residential placements, and mostly adults, but again, they're longer term placements. That becomes that person's address, so we really need to get to grips with what's happening with them. They are followed through case management processes, either through the local authority or ourselves, and some of them have care coordinators if they've got they're on the CPA, the care programme approach process. But again, it's people placed where we can't see them every day, so we need some assurances from the host commissioners in those areas as well. So moving on, this is the bit that I didn't fully author, so if there's any questions on that, I may have a few gaps, so I'll apologise now. That's just really describing what's happening with the CTR, the care and treatment review process, and the care education and treatment review process for children and young people in Barnsley, and how we're set up in our respective transforming care partnership cohorts there. And how we're part on the Assuring Transformation platform about those people. They are monitored as per the national guidance, and which is now a policy as from today. It's just landed today. The Dynamic Support Register and CTR policy has just landed today, so we're going to be working through that. But we have got quite robust arrangements in place, and that bit of the report describes the safe and well checks that happened last year. Which were quite intense, and those were looked at by a panel in Sheffield, and we had some really positive feedback from that, and it really was a testament to the fact that those patients are followed really regularly by the case managers. Then we're moving on to page 5 and 6, which is the learning from lives and deaths of people with learning disability and autism, as it's known now, the LEADER for short. And that just describes that we have currently 21 deaths notified. They're from between early 22 and now, late 21, early 22 and now. And just describes the position, the reviewing position, which we are very short on reviewers across South Yorkshire. That's a national picture as well. So we do have a backlog of reviews in Barnsley, which is similar to everybody else in South Yorkshire. It's a pro rata really, because Sheffield's got a massive population and a bigger LD population. They have more outstanding reviews, but we are all still in the same place. There are plans to develop a South Yorkshire reviewer team with some admin attached as well, and those discussions are currently ongoing with our chief finance officers and chief nurses across South Yorkshire. So again, looking at our reporting, our governance, we report into the South Yorkshire Strategic Health Inequalities Group for the governance across the ICB and ICS. And we report in our figures through then to regional and national leader teams there. And our reviews and learning into action plans are submitted every month as a highlight report. We do have a learning into action plan in place in Barnsley, which is informed now by the themes and trends we get from the reviews that are completed. I think we've had 80 some reviews completed so far, and themes are around the national themes, but there are some that are quite pertinent to Barnsley that we have included in our learning into action plan. And we'll be reporting on leader and our steering group activity. You've noticed there we've got a steering group, which is a requirement. That's in quite early days, because we were a bit behind the game in Barnsley with leader, but we're now in real time. We've caught up and our steering group's launched, and we're sitting that governance now under the Learning Disabilities and Autism Delivery Group and the MHLDA Partnership Board as well. So we've got that governance in place there for the leader. I'll leave it there for any questions now. That was just a really whistle-stop run through.
Thanks, Jo. It's really, really helpful. Just need to note we do have the leader business case, and we're discussing with Lee Outhwaite, the Chief Finance Officer, about the resourcing of that. It's really quite important that we get behind that. I put in the chat earlier on, I know everybody's on Teams, but the other thing is really about is accommodation and support. Housing and support is a real issue for people with autism, people with learning disability, and people with mental health needs. And to that end, I've sort of convened a regional conversation with NHSE, all of the 15 directors of adult social care, each of the MHLDA programme leads across the ICSs in March to have a real deep look at housing and support and any other barriers around MHLDA, because we observe CHC policies as they apply into some places are very odd and curious. We observe that some legal support is a bit odd and curious and not timely. So I think there's a whole conversation that we're going to have around that in March, so we can put our collective shoulder to the mast.
Thank you, Chair. I think I'd like to understand a little bit more of what training and checklists, people that are doing the monitoring, people that are placed on mental health, learning difficulty and autism across all the pathways. Obviously, there are things I cannot say for obvious reasons. But what I've seen on the ground does not agree with the assurance in this report. I don't know how you can improve it yet, but all I'm saying is I know the way you're doing it, and I think it's great you're starting doing it. But what is out there and what is happening to people that are placed out of area across the whole of that, the doctor rehab, acute, PQ, forensic from low to high. High is probably better than low, medium. It's not very good out there for people that are out of area. Sorry to be blunt, Chair.
Okay, it's a perception, it's a view. You're sharing a view with us, and you know we're hearing the view. But I guess others want to come in. Jane.
Yeah, I just want to ask, as I did at a previous meeting, we're talking to commissioners and we're going in there and case managers are going in and checking things out. Why aren't we talking to independent advocates? They're there, especially in forensic services. There's often an independent mental health advocate that's actually working into the hospital or the care setting. I've worked with them in the past and they really know what's going off inside the places that they're working at. Have we looked at using them as a resource?
George, we should be. We should most definitely should be. George, you want to come back in?
I think that's where it goes back to the individual case management and how we need to get more assurance that those conversations are happening. I mean, I imagine some case managers are very closely following and asking the advocates what is happening. Some may not be. And again, around trying to develop our quality assurance and quality and safety assurance processes, we need to get to grips with that really and understand what good case management is and what it needs to look like and what those conversations, the quality of those conversations with people like advocates, people who are living and residing in those facilities and their representatives and families. We really need to get to grips with that. And that for me comes down to case management, speaking as a long-term, sort of LD nurse and case manager. That for me is a really key. And that's something we want to develop.
Yeah, Mark, can I suggest you want to pick up a conversation with Joe outside of the meeting? That'd be really helpful.
Yeah, I think you're right. It's getting the case managers, the advocates, patients, the family all involved, because that's when you'll find out what's going on.
Yes, it's not about a form to be filled.
No, but it's how you record the information.
It's about an approach. Yeah, you're quite right. So, Joe, will you pick that up on with Mark, please?
I will. Is that for just the non CTR cohort, the non TCP, or is that across the board, Mark? Because I'm aware there's a process in place, but we need to get to grips with if that is, good.
All right, lovely. Thanks, Joe. Any other comments? No. All right. Thanks for bringing that in, Joe, for joining us today.
Thank you.
Thank you. Moving on to item 17, risk and governance. Richard.
Yeah, thank you. This will just be a very brief, I think, sort of update, because I think we've touched on some of the governance type things earlier on in earlier discussions on the agenda. I did just want to just elaborate slightly on a conversation we had a few minutes ago about the development of the risk management framework for the place. So there has been work going on in the ICB, led by colleagues in the ICB's sort of corporate and governance team, to develop a risk management framework and an assurance framework for the ICB. That's now reaching a point where there is a sort of risk register, which has been built up initially from the sort of risks carried over from the old four previous CCGs. But those risks have been sort of reviewed with risk owners and so on to make sure that they remain relevant in the new world. And there is now going to be imminently a process established whereby those risks will be reported through into our places, initially through the local senior management team, and then ultimately into this meeting as well. So we are on the cusp, if you like, of having that routine arrangement for reporting and considering risks, and that will become the mechanism where we can pick up and formally record items along the lines that we talked about before, the ACON unit being one. But as we continue in our work, I am absolutely very confident that there'll be other similar items as well, and that will become the mechanism, I think, for monitoring that, really. So that was all I was going to say, Wendy. If anybody has any comments, obviously, or questions here, I'll do my best to answer.
I think that's pretty much a straightforward update. Is there any questions for that? Thanks, Richard. Yeah, thank you.
Thank you.
Okay, let's move on to item 18, Roxana.
Yep, so I'll just quickly touch on item 18 and then lead straight into item 19, if that's okay, Wendy. And then we've got a few people who have joined us on Teams virtually. So Adrian's joined us, Louise King and Steve Loach has joined us to present some of agenda item 19. So just in terms of the Barnsley Place financial position, we're still on track to deliver a balanced budget position based on the allocation we received as a place from the ICB. We are being pushed to support the wider system to improve our position and Chris Thickett from the hospital and myself are meeting with the ICB Director of Finance on Monday to talk through what we might be able to do to support the system more widely. So currently this system has a £25.5 million unidentified efficiency to be able to deliver its requirement to deliver overall financial balance. So there'll be a further update on that. We have done quite a significant deep dive as part of our month 9 reporting, which is not necessarily covered in the paper, which is concluded now, which means we probably will be able to improve our position. How much by it's still a little bit up in the air at the moment because we're seeing continued significant pressures on prescribing. And that's linked to no cheaper obtainable stock, which is causing, it's a national issue. So NHS England are aware, and there have been some indications there may be some further additional funding, but we've had no confirmation of that yet. So I just wanted to kind of just say we're on track. We think we'll deliver what we set out to deliver as a place. Some further work to do across the ICB, I think it's fair to say, and the wider ICS. So that includes our NHS providers in South Yorkshire. So unless anybody's got any questions on that, I'll move straight into 19. Yeah.
Nope. Got any questions yet?
Okay, thank you. So Steve's just going to start presenting. Can you present the slides up, please?
Do you want to introduce themselves?
Yeah. So Steve's, if I just explain what we've been doing. So the Finance, Performance and Efficiency Group, which is a subgroup of this committee, has been working on understanding the financial position across the place. So a group has been established of finance leads across the system, supported by directors of finance in Swift, the council, and Barnsley Hospital, and myself, to really start to pull together a clearer understanding and a clearer picture of what the position in Barnsley looks like. So we've got the first draft of that, which looks at this financial year, but the group are really going to start to focus on next financial year and what that might look like as we progress. So I'll hand over to Steve, but Steve, Louise, do you want to introduce yourselves?
Yeah, thanks, Roxanne, and thank you for inviting me today. I'm Steve Loach. I'm Head of Corporate Finance at the Council.
And I'm Louise King. I'm Head of Financial Planning and Development at Swift.
So I'll just jump straight into the slides. Next slide, please. Yeah, so like Roxanne has just mentioned, we sort of came, the group of sort of 4 heads of finance came together just before Christmas, and were ultimately tasked with pulling together an overall sort of place health financial position. What we started to work on was a forecast position for 23-24, and we worked on that from month 8. And key thing sort of around that was obviously the alignment across the 4 organisations, just to ensure sort of consistency. So making sure the cost categories, etc., and terminology were sort of aligned. Next slide, please. So we've pulled together the initial draft report, and that currently shows a financial forecast position for this financial year for the partnership as at the end of November, to be around about a £12.5 million overspend, and that's against a planned deficit of 5.7, resulting in a variance around about 7 million. That's after adjustments for additional allocation from the Integrated Care Board, as well as adjustments made for depreciation and income from Barnsley Hospital. The main pressures across the piece are staffing, both in terms of recruitment and retention, as well as agency cost. Social care packages, both within adults and children's, and that includes a rise in the cost of home to school transport, as well as prescribing and drug costs. Those costs and pressures have actually been partly offset by non-recurrent flexibilities, including underspends and additional grant income. Moving forwards, however, we've initially calculated a recurrent underlying position for 23-24 of a £61 million deficit, but that is before any efficiencies have been built in, and that's one of the next part of the plan in terms of looking at that position in more detail. Next slide, please. So all this slide does, I'll not go into too much detail, but effectively all this slide does is presents the overall position, and it presents it by individual organisation as well. What I will do on later slides is actually go into some of the more detail for each individual organisation. Next slide, please. So in terms of work in progress, our main focus now, like I've mentioned, is moving on to 23-24, where what we'll look to do is refine the report further, and we'll look to offset income and expenditure where it's linked, so that in future we're just reporting that net position. We'll also be creating a RAG rating and RAG rating thresholds, and that'll make obviously reporting a lot easier to understand and read. We're currently starting to look at including a collective position both on capital expenditure, efficiencies, and the recurrent underlying position moving forwards, both in terms of the short term and over the medium term. And then finally, we'll also seek to add additional information where available around national targets and performance, staffing including vacancies as well as sickness levels. Next slide, please. So this slide quickly provides a quick overview in terms of the position for Barnsley Hospital, and they're currently reporting around about a £9 million deficit, which is in line with their plan. COVID positive bed occupancy stood at 5% when we pulled this report together, which is way above the 1% national planning guidance, and obviously that's having a clear impact on cost. The forecast assumes that NHS England will not claw back the £7.6 million elective recovery fund income, but there are further risks around about 11.6 million, which all but 0.7 will be mitigated against the ERF monies if that's not clawed back. Delivery of efficiencies, however, a £3.2 million behind plan this year, with a year-end forecast of 4.1 by the end of the year. Next slide, please. In terms of the council's position, they're reporting currently a £5 million net deficit, but that's likely to worsen as we move towards the end of the year. The main pressures are in children's social care and home to school transport, and that's as a result of rising demand and cost, together with staffing levels, which is obviously causing significant concern. These pressures have been partly offset by non-recurrent underspends in adult social care and public health, and that's due to additional income and lower than anticipated demand for some services. However, direct demand pressures across the individual areas stand at around about 16 million over the next 3 years, with an efficiency plan in place to address that, including 5 million quid's worth of efficiencies to be delivered in 23-24, and the further savings to be delivered via a transformation programme both in 24-25 and 25-26. Next slide, please. In terms of the position for Swift, this is slightly better, with a £2 million surplus projected at present, and that's expected to meet the planned surplus of 3.2 by the end of the year. As with other organisations, recruitment and retention is a major concern, both with the cost of agency staff currently exceeding levels that's been set by the trust. But outer area placements remains the biggest cost pressure risk for Swift. Efficiencies of 4.5 million are being delivered in line with the plan, although mostly these are from non-recurrent means. Next slide, please. And finally, in terms of the Integrated Care Board for Barnsley, that's reporting a balanced position after adjustments, although significant pressures have been reported on continuing healthcare and complex cases, as well as prescribing costs. Risks totaling 4 million have been identified, but are expected to be fully mitigated. The £3 million efficiency target on prescribing is behind in terms of delivery, but is expected to be delivered by the end of the year. But the board has underlying deficit position of 22 million, which is an increase from 4 million this year. And that's me done. I think next slide, you, Roxana.
Yeah, thank you. Thanks, Dave. So I'd just like to thank Steve, Louise, Rob Pascal and Jenna Miller for pulling this information together, because it's the first time we've seen it all together in one place, and I think really starts to show how we want to transparently work together in terms of understanding each other's positions. So thank you to them. We did discuss the slide deck at the last finance performance and efficiency group, and just felt that actually there was only so far we could go from a finance perspective, and actually what were the key things we needed the partnership to help us with, and the delivery group to help us with, in terms of closing that financial gap. So the things that we looked at were actually we've identified an initial gap of 61 million. There is some further work to be done on that. We're starting to get a bit more clarity on planning guidance, so there will be a refined version of that coming through into this committee later, probably in March, April, maybe by the time we get there. We're looking at the internal actions we can take and that's both as directors of finance and chief finance officer, but also working internally within our organisations, and what are the things that we can do internally to reduce costs and therefore try and mitigate and close that gap. The ask of the partnership fundamentally is actually, what are the things we can do that are in addition to all the things we're doing in silo as a partnership that will effectively reduce those costs further in our system or make better use of that resource. And I think that for me is where the Barnsley, the place plan comes into its own, because actually how will that address the financial issue, performance issue, and closing the gap around health inequalities and improving care for patients and the people of Barnsley. So that's the ask of the partnership, really, is to quite quickly, because quite clearly we're going to have a deficit plan submission if we don't start to address some of these issues moving forward. So that was the ask from that group, which consists of myself, Adrian, Chris Thickett, and Neil Copley and Jamie. Okay.
Thank you very much. I can see there's a couple of questions in the chat which have been answered. I think we've got that sort of call to action, I'd call it really here, I think, which is about pulling together the correlation between this picture as a system, performance as we understand it right now, and those programmes of work. I think that's what we're saying. There's got to be a connected piece of work, and we've got some time in the February partnership about gripping some of that into some of those really sort of transformational areas of work that we want to try and focus on, that ideally improve outcomes and help us to contribute to that position. Okay, I think it was Richard and then Julia.
Yeah, thank you. Thank you for the clarification in the chat. How does that SWIFT position play into Barnsley? How do we go from SWIFT as a whole to whatever SWIFT plays into the Barnsley system? That's the first question. And secondly, just a comment. I guess some things we talked about today, some of our solutions here have to be about really well joined up efficient pathways for local people that don't lead to unnecessary hospitalizations or more costly pathways. So I guess it's just, again, reinforce the need for us to work really well together as partners.
Agreed. Julia?
Sorry.
Oh.
It's just go on.
Oh, Adrian?
I was just going to respond to Richard's question, if that's okay.
Please, yeah.
So as you've highlighted, Richard, it's the whole SWIFT position, and as you know, the reporting requirements for ICB means that we can only report into one ICB. So formally, we report into West Yorkshire. What we've committed to with the Barnsley Place work is that whilst we're in a financial upside position, that we can contribute to the wider Barnsley financial challenges. So we haven't got into the granular detail of splitting our costs out to a Barnsley Place, because some of the things we will do at trust level rather than at place level. But we do commit to make sure that where we've got financial upside in SWIFT for the Barnsley Place, that it feeds into the Barnsley position. There's just a level of complexity to how we actually transact that to make sure the resources are protected for Barnsley. but we're working through that with Roxana and the others as Roxana mentioned.
Yeah, thanks, Adrian. I think we've all got bits of the jigsaw I think we can put together on that, can't we, Adrian? But Roxana, do you want to come in?
Yeah, I just think it's really important that Swift does support the Barnsley system. So whilst their financial position isn't necessarily reported in our ICB, Swift do support the system with conversations around the level of investment, etc., required in some of the services delivered by Swift. So I think it's just really important to note that that's fundamentally, I suppose, how we transact the Swift contribution to Barnsley.
Okay, thank you. Julia, do you want to come in?
Yeah, sorry about that. I suppose just to comment how brilliant it is that this group's meeting and, you know, that Steve gave us an overview of everyone's finance. I don't think that's ever happened before in terms of that kind of group ownership. And also just how important it is in terms of things that could really come to bite us. So, you know, a quick example, drugs funding. So we're getting over £1 million of combating drug funding from the government, but it's based on the fact that we don't reduce any of our investment from any of our partners. So if, say, the NHS took their 200,000 or whatever out of it, that would risk that £1 million. And this is why this group's so important, so that, you know, one bit of the system thinking, oh, that's a saving, could actually just take out, you know, a lot of money from the whole system. So I just really welcome the fact that the group's doing it. Thank you.
Thanks, Julia. I think that's probably echoed really. So huge thanks to colleagues that have joined us today, our CFOs that are putting the shoulder to the mast in this space and working collegially together. So thank you for bringing this paper in. If we want to move on, any final comments, Roxanne? No? Okay. Let's move on to item 20. I'm not going to spend a huge amount of time on this because I feel like I've had about 400 conversations about discharge and discharge funding over the last fortnight. And equally conversations about how much performance management there's going to be around this money, which is interesting to say the least. So it is what it is. You've got the paper in front of you. We worked together, usual theme, we worked together to try and identify those schemes of work that we thought would make a difference on discharge. I think what we'll probably find is some will go at a faster pace than others for all the issues that we understand around workforce. We'll find some of that will take a little bit longer to get mobilised. But we will bring a report forward in due course around the impact of the funding. I think that's what we need to see. It's the impact and the difference that it's made. Clearly within the ICB, there's grip. I think it's through the Acute Federation or UEC?
Oversight group.
Yeah, get lost, Bob. Thank you for that. In terms of gripping the overall impact, I think, isn't it, around these schemes across South Yorkshire? I'll probably leave it there. Unless anybody's got any questions about the discharge funding, it's there for you to know right now. Nope. Okay, so you've got in front of you the next items around the item 21, which is the dashboard. I think we noted earlier on anyway the need for this to evolve. We've got a piece of work to do to continue to make sure that this dashboard pays attention to the right things and a balance between our overall ambitions and transformation ambitions, as well as some of the must-dos on performance that we know we're going to have to be accountable for. So you have a note there from Jamie and with regards to this paper and some key issues around our performance. So I think I'm just going to ask really whether or not anybody's got any particular comments to make on item 21 and 22. I'm conscious of the agenda. I don't really want to skip over it, but we've got 10 minutes left and I like to finish meetings on time. So has anybody got any comments at all? Assuming you've read it. I'm not going to go through it, Bob.
I would just try to link it with bits of this discussion in the meeting today is for me is that I think it's sensible to kind of get the must-dos in there so we're in the current context, but generally what tends to happen, and Jill's kind of said today, is we're performing ahead of the pack in terms of the kind of the new metrics as well. In terms of delivery, I think the big challenge for us as a system is we've just been coping with what's been thrown at us. There has been some transformation within that, which may need to be to cope with extra demands here and there and stuff. It'd be, I think we really need to get much more on the transformational footprint. There are elements of transformational work to what we do, but I think we're a bit too sporadic at the minute. We need to get much more strategic. We've got longer sessions with the development group. We checked in on Tuesday. We've got a lot of extended session in February where we're going to really get into that a bit more. Yeah,
we do definitely need to nail that down, Mark.
Yeah, I think we need to look at what mental health learning difficulties and autism data we are showing up, because I think there's biggish gaps. Been my hobby horse for 8 years, if people have been listening to me for that long. But yeah, we need to get that right.
I mean, that is a really good point actually about trusted and accurate data, and very particularly on MHLDA, there is a challenge, isn't there, really, but getting to the truth. I think around MHLDA, there's no doubt about that.
Without data, it's difficult to manage and know where we want to get to.
Yeah. Okay. Julia.
Yeah, just we will pick it up when you talk about the health inequalities in the workshop, but really, really good that we're starting to have those charts about health inequalities. I still think, and you, Wendy, you said this, we need to kind of make that a bit clearer. So, rather than just having loads of charts, I'm almost having a summary about what this means so that it helps us as a system be more accountable. So as an example, the A&E attendances, big gap between, highest but in most deprived groups. But then when we talk about GP referrals, really close, it kind of makes me go, that bit of an inverse care law playing part. So but what's really good is it helps us start really asking those questions. So really welcome it.
Thanks, Julia. I'm not going to dwell on this too much. Is there any other comments at all on these documents? We note that there's more for us to do as system leaders to grip it, to make it determined and focused and purposeful and accountable and measurable. And that the governance underpinning it is smart and purposeful too. So it's quite a bit of work for us to do, Bob, me, others as well, to really get to that point in time. All right, okay, if there's no questions on that, that deals with item 21 and 22. You've got item 23 on your agenda, which is the senior management, our health and care senior management team decisions that we have taken recently. Some helpful stuff on there, in particular, being able to agree at least for 23-24 funding for the VCSE. For Barnsley CVS and VCSE work, which gives them some helpful stability, at least for the next 12 months, to be able to plan ahead. And some other observations in there in terms of the decisions. I just wanted to for you to note those. I do want to also pick up at the end of there, you can see a CHC independent review. Jane, do you want to spend something just to quickly mention what that's about?
Sorry.
Sorry, I know I'm terrible at handing up people. Go on.
Right, so we've had some discussions for probably about 12 months about integrating further CHC with our local authority colleagues and obviously social care. So we've been looking at that. We've had some issues within the team with regards to sickness and maternity, which obviously compounded lots of issues that we had. So we've appointed a lady called Carrie Wallerton, who's got a lot of experience. She's been a chief nurse in North Yorkshire, and she started to do an independent review of our CHC service. We have got an event, and I think it's gone in the calendar now. It's like a workshop in the beginning of March, to what does good look like, what could the future look like. So invites will be going out to partners, but it is to review. It's an independent external review on CHC.
So we're probably leading that in many ways for the other systems to think about and follow at some point. But sorry, other parts of our system to consider. I was sharing that work yesterday at the ICB executive. All right, thanks for that. Any comments at all on any of those items on the paper at number 23? No, you've got some other minutes of the Quality and Patient Safety Group the 10th of November there, item 24, and equally finance and performance at 25. Is there any any points that anybody wants to raise from items 24 to 26. We're doing well here, so I'm getting back on track. I'm trying to go as fast as I can. Is there any escalations we want to make to the Health and Wellbeing Board from the conversations today? No. Thank you. Anything else, any items of any other business that anybody wants to raise? A long meeting and we've travelled some ground, so if not, I will ask for any reflections about how well the meeting's been chaired. I don't mind. Please just say it. How well? If I think I've chaired hopelessly, I do want you to say it. How well the meeting's gone today, because we have crammed an awful lot in. I do think there's just something about the timings and how we structure the agenda still. So we need to work on that and find a better balance. Richard.
Thank you. I think you chaired it very well. The only thing I would have welcomed is a break halfway through. It's a long meeting without a break.
Yeah. Point well made. Although I did gift, if you were in the room, I did gift grapes and tangerines as my random act of kindness today. So yeah, you're absolutely right. Well, we will do that. Thank you for that, Mirban.
Agree with Richard. I think the break would be useful. The other thing I'd say in the papers, we're next to the agenda item for those who've got the combined file. If they could the page number for where the enclosure is, when you're trying to scroll up and down, it would be really useful to go to page 165 for item 17, for example. It will just help us. Thank you.
Oh, that's really helpful. These really practical suggestions. Yes, thank you. Kirsty.
Yeah, thank you for the grapes and oranges. That was great. I think for anybody watching this back, so there'll be people that are watching this back, I think it's really helpful that we did all the introductions. So I think that was really positive. And I think for people in the room, it's really difficult to see the slides at the end. So even if we're not circulating them, we could perhaps put it in the meeting chat for colleagues to look at who've got access to, because I think that's the other thing I'll just reflect back on. But if you're actually taking part in teams, you get a really good view of it. And if you're watching on video, you can see it. So it was just that mix.
All very helpful feedback. I think the other action that we probably need to take is taking this on the road. Because we've been in Hilda House for a few times. And I know it's about hybrid capability, but we really do need to think long and hard. Sorry, I know people are like, oh my God, what's she doing there? But really, Kirsty particularly is like daggers in the face. So yeah, but let's think about how we might do that, at least, in some way, shape or form. Okay, Bob.
Yeah, I had two observations. I really like the way that we started the meeting talking about a resident story, and I think that positioned a lot of the discussions, especially in the first half, and then linking that with the paper and residents as well. And but I mean, it's been a good week for the voluntary sector this week, obviously with the hospice, and I think you've said congratulations as well. But that we talked a lot about the voluntary sector today in a very meaningful way. I heard, strong voice, from people in the room, but also from Jane. I don't know if she's on anymore. Which we've listened a lot, and heard that we just talked NHS. I think we're having quite a, that came across to me today in a good way. So I think that's positive.
Right. Well, we've got 2 minutes left. So thank you all for joining us today, and have a good evening.